Hi guys, give me a thumbs up if I'm loud and clear live. Let me know that I'm live so that we can begin the session. I'm waiting for a thumbs up from you guys. Once I know that I'm live, we will start with the first question. I have 20 questions for all of you today, and I will take maybe around 50 to 60 minutes. And in this period, we will remain focused on taking the essential points from this question. I'm not trying to deviate away from the core essence of the question. It's not going to be a very detailed discussion. It is about knowing extremely high yield questions. Okay, so it appears that I'm live. So without wasting the time, let me begin with the first question. Okay, these kind of questions you have started seeing recently, last 1 or 2 years. First, these kind of questions made their way into INICET, and one similar question appeared in the NEET PG. This becomes important because physiology, they are already covering about the pressure tracings with respect to cardiac cycle, so we can anticipate pathological questions also. Okay, so here is the question. The following hemodynamic tracing is characteristic of which of the following disorders? Four options are there: aortic stenosis, aortic regurgitation, mitral stenosis, and cardiac amyloidosis. This is the tracing that all of you are seeing. Okay, so if you get any such pressure tracing of cardiac cycle, you should be able to answer that question. So let me make it a bit conceptually simple for you. Here you are seeing two pressure tracings, right? There are two graphs. One is this purple colored graph, which they have mentioned that it is a left ventricular pressure tracing. The second one is aortic graph, right, in red color, which is showing the pressure changes in the aorta, and they are asking in which hemodynamic anomaly like aortic stenosis, regurgitation, mitral stenosis, or cardiac amyloidosis you will be seeing such a tracing. Okay, I will wait few seconds for your answer, but after that I'll give you some quick points that will help you to handle these kind of questions. Activating, I will be sharing the annotated PDF at the end of the session on the Telegram group. Okay, anybody is giving an answer? If this is totally new to you, don't worry, this is going to be very, very easy, right? So what are we trying to do here? We know the anatomy of the heart, right? We know heart. Now this time, this question is concerned about left ventricular pressure changes and the aortic pressure changes, right? So you have left ventricle and you have aorta. So we are looking at the pressure throughout the cardiac cycle, what is happening in left ventricle, what is happening in aorta. Okay, now tell me, when the when the left ventricle gets into systole, what is the first phase of systole? When left ventricle starts contracting, first phase of systole is what? Mary Sandra, yes, spot on, you're absolutely right. Sanju Hazra, Chirag Gohel, yes, it is a pressure tracing of aortic stenosis. Okay, what is the first part of the left ventricular systole? Right now I'm talking about left ventricle, right? It is completed diastole, so that means it is now filled with blood. Left ventricle has blood in it. It has completed a diastole. It is getting into systole. So the first part of the systole is what we call as isovolumetric contraction, right? Now what is the characteristic of isovolumetric contraction? In the beginning of the systole, isovolumetric contraction phase, mitral valve is closed, aortic valve is closed, right? And the left ventricle is contracting. It is contracting against both closed valves. So when it's contracting against the closed valves, the blood is not escaping into the aorta. So the volume of the left ventricle remains same because the blood, whatever is there, it is not escaping. It remains same. So inside the left ventricle, what will happen to the pressure? Will it rise or remain same? Left ventricle is contracting, valves are not open. So you imagine a balloon you have filled with air and you have held it tightly closed and you're pressing it. So inside the balloon, pressure is increasing, right? All valves closed, left ventricle contracting, pressure is increasing. So that is what you will see in the left ventricular pressure tracing. So initially the pressure is going up. This portion of the LV tracing, it is representing, what is it representing? Isovolumetric contraction. Okay. After that, what is the second phase of the left ventricular systole? The second phase of the systole. Now, once the LV contracts during the isovolumetric contraction, pressure in the LV becomes more than the pressure in the aorta, right? So LV pressure exceeds the pressure in the aorta. That leads to opening of these valves, right? Aortic valve opens. Once the aortic valve opens, the blood starts flowing from the left ventricle to aorta. Now tell me what happens to the pressure in the left ventricle. What happens to the pressure in the left ventricle? It will start dropping down, right? As the blood from the left ventricle starts emptying, less and less. Yeah. So initially you have a rapid ejection and then a slow ejection. So during this period, rapid ejection, yes, the pressure shoots up a bit, and then as the blood gets emptied, From here, blood is now moved to aorta. So here volume is less, the pressure starts dropping down. That is what you will see here. So this upsurge, you are seeing the rapid ejection, and then as the blood is almost emptied, the pressure starts dropping down. Okay. Now, in a normal aortic valve, what happens to the aortic pressure? So I will make one important statement that all of you have to remember. In a normal physiological state, when the aortic valve opens, right, this valve opens completely. The aortic valve opens completely. So at the peak of the systole, or in the peak phase of your left ventricular contraction, because there is no barrier at the level of aortic valve, the pressure in the left ventricle will be equal to pressure in the aorta. It is like one chamber. Aortic valve is completely open. It is not creating any barrier. It is completely open. So there is one chamber. It acts like one chamber. So in normal physiological state, LV pressure is equal to aortic pressure. So normal aortic valve tracing would look like this. So somewhere here only the aortic tracing will also go along with the LV, because as the valve opens completely, it will coincide. So at peak, you will notice that aortic valve is peaking. Aortic pressure is also peaking along the LV pressure. Okay, but what do we see here? What do we see here? The aortic tracing is blunted, right? Its peak pressure is not equal to the peak pressure in the LV. It is blunted. Why that can happen? That can only happen when the pressure that is building in the left ventricle is not transmitted to the aorta, right? That is only possible when you have a aortic stenosis. So if the valve is not completely open, whatever pressure you created in the LV, partially only it is getting transmitted because the valve orifice is narrowed. So in that case, in aortic stenosis, what happens? In aortic stenosis, you have LV pressure, which is more than aortic pressure at the peak of systole. At peak of the systole, LV pressure is more than aortic pressure. Right? So there is a gradient created, and that gradient is what we are seeing here. LV pressure is this much higher than the aortic pressure. So now you tell me what tracing is this suggestive of? It is suggestive of aortic stenosis, right? It is suggestive of aortic stenosis. It clearly says that there is a gradient between the pressure in the aorta and the left ventricle. A gradient is not expected at the peak of systole if the aortic valve is normal. Can we apply the same principle to the right side of the heart? If I take a right-sided tracing and if there is a pulmonic valve stenosis, will I get a similar looking tracing? Yes. Same, the systolic events are happening on the right side also. So if there is a pulmonic valve stenosis, the tracing will be similar. Instead of LV pressure tracing, it will be RV pressure tracing, and this will be pulmonary artery tracing, right? Okay. So that's our first question. Even if you have not understood this, if you notice that there is a gradient between the left ventricular pressure and the aorta pressure, it is suggestive of aortic stenosis. Okay, cool. Now let's go to the next question. Please pay attention. This is little conceptual question. We have a 64-year-old who was treated for an ischemic right hemiparesis. So this patient had a stroke. He had developed right-sided hemiparesis. He has now luckily made good recovery. He has made a substantial recovery. His echo was done. Part of stroke evaluation, they have done an echocardiogram because there are a lot of cardiac conditions which can contribute to the formation of stroke. Okay, so he has undergone an echo at the time of discharge, and it shows that there is aortic stenosis. There is aortic stenosis. The ECG of the patient showed sinus rhythm. So we have not found any abnormality on the ECG, but patient had aortic stenosis. Now the question is, which of the following options would you suggest for prevention of further episodes of stroke? Would you give him antiplatelets and statins, or would you give him anticoagulants using vitamin K antagonists, or would you give him a newer oral anticoagulants, or will you start him on antiplatelets and vitamin K antagonists? What would be your choice? Okay. So tell me, which cardiac anomalies are associated with the risk of stroke? Jay Suresh, sure, yeah. Okay, all of you are saying option C, anticoagulation with newer oral anticoagulants. Okay, now tell me, which cardiac conditions are associated with the risk of stroke? Which cardiac conditions are associated with risk of stroke? Let me ask one by one. Okay, Chirag Gohel says option A. Okay, is mitral stenosis associated with risk of stroke? Is mitral stenosis associated with risk of stroke? Yes, mitral stenosis can lead to atrial fibrillation and thus it is associated with stroke risk, right? Why atrial fibrillation leads to stroke risk? If the atria is fibrillating, not contracting, right? You remember Virchow's triad, 3 components for formation of a clot. One of them is stasis or stasis. So when left atrium is not contracting, it is fibrillating, the blood is getting stagnant there, it is not moving well. So this stagnation of blood will facilitate clot formation. Once a clot is formed, it is very easy for the clot to escape from the left atrium to left ventricle. From left ventricle, the clot can go into the aorta to the carotids and can cause stroke, right? So mitral stenosis, yes, it can cause. Can mitral regurgitation cause stroke? Can mitral regurgitation cause stroke? Yes. Mitral regurgitation can also be associated with atrial fibrillation. Why mitral regurgitation can be associated with atrial fibrillation? Because anything that dilates the left atrium, anything that increases the size of the left atrium can increase the risk of development of atrial fibrillation. Okay, both of them can be associated with. Okay, now the third question is, can aortic stenosis be associated with increased risk of stroke? Can aortic stenosis be associated with increased risk of stroke? Yes, the answer is yes, it can be associated with increased risk of stroke. So Dhawan says yes. Okay. Can anybody explain why it is associated with increased risk of stroke? Again, very same mechanism. Okay. So when you have aortic stenosis, this valve is narrowed, right? So when the aortic valve is narrowed, your left ventricle is doing a lot of work. It is putting extensive effort to pump the blood out into the aorta, right? It is like in the gym now. But over time, when left ventricle is overworking, it develops left ventricular hypertrophy, right? And please remember, whenever muscles hypertrophy, relaxation gets affected. Muscle relaxation decreases. So left ventricular hypertrophy means during the diastole, when they should relax well to receive the blood, it is not going to relax well. So if it is not well relaxed, left ventricle contraction force is increased because it is bulky, muscular, but it is not relaxing well. So when it is not relaxing well, what will happen to the flow of blood from left atrium to left ventricle? It will be impaired, because if the LV is well relaxed, then it can receive the blood easily from left atrium. But if LV is not well relaxed, then left atrium has to put extra effort to push the blood into a non-compliant hypertrophied left ventricle. So that can lead to left atrial enlargement. Over time, left atria also becomes hypertrophied. So in aortic stenosis also, you can have left atrial enlargement, and thus you can have atrial fibrillation. You can have atrial fibrillation. So it can lead to left atrial enlargement, and that can lead to atrial fibrillation. And once there is atrial fibrillation, there is risk of stroke. Okay. Now, before we move on, right, tell me the risk factors for development of atrial fibrillation. Sorry, aortic stenosis. What are the risk factors for development of aortic stenosis? What is the most important risk factor, or what is the most common cause for aortic stenosis? The most common cause for aortic stenosis is age-related degeneration of the aortic valve, right? It is calcific degeneration, which is age-related degeneration. So age is obviously a very important risk factor. Elderly, you are likely to develop aortic stenosis. Second, okay, aortic valve, the degeneration is occurring because of the calcification, and the starting point of the calcification is development of cholesterol deposits on the aortic valve. Just like how vascular atherogenesis is happening, even the aortic valve is also getting affected by the atherosclerosis, right? So the underlying process here is atherosclerosis. So anything that causes atherosclerosis to get accelerated can also cause aortic stenosis. So your hypertension, diabetes mellitus, these are all risk factors for atherosclerosis, right? So the risk factors for atherosclerosis are risk factors for aortic stenosis also. Are risk factors for aortic stenosis. So that includes your diabetes mellitus, hypertension, dyslipidemia. So anyone who is having all this cluster, right, he can develop a coronary artery disease, he can develop aortic stenosis, he can develop stroke also. Okay. So now with this information, let us go back to the question. In this patient, he had a stroke. He has made a recovery. Echo showed aortic stenosis, but ECG did not show any abnormality. Yes, we can anticipate atrial fibrillation to occur, but this patient does not have. He is having sinus rhythm. In the aortic stenosis echo also, they have only mentioned aortic stenosis. They have not mentioned that there is left atrial enlargement, right? So neither there is left atrial enlargement, nor they have mentioned that there is a clot in the left atrium, nor they have mentioned that patient is in atrial fibrillation. Okay, so the risk factors that led to ischemic stroke are the same risk factors that led to aortic stenosis. So we don't need to do anything specific for aortic stenosis. If this patient had ECG evidence of atrial fibrillation, I would have given him anticoagulation. I would have considered anticoagulation. Right now, we don't need anticoagulation. So we only have to primarily address his stroke prevention strategies that generally we would do for any stroke patient. Okay, so most of the options now become nonsensical. I don't need to give him warfarin. I don't need to give him any newer oral anticoagulants. I don't need to give him a combination of antiplatelets and anticoagulants. All that I need to do is give him antiplatelets and statins for the further episode of stroke from getting prevented. That's it, right? Okay, one last question. If at all I mentioned that this patient has ECG evidence of atrial fibrillation, then what option you would have chosen? If this patient had atrial fibrillation, what option would have chosen? Will you consider warfarin? Will you consider newer oral anticoagulants or antiplatelets and vitamin K antagonists? Can we use newer oral anticoagulants in such a setting? Okay, I want you to remember one important point. If you have a valvular heart disease, particularly of rheumatic origin, okay, in that case anticoagulation always has to be with vitamin K antagonists if it is rheumatic in origin. If it is non-rheumatic, you're open to consider newer oral anticoagulants as well as vitamin K antagonist, and we all know that newer oral anticoagulants are better than vitamin K. So aortic stenosis, is it caused by rheumatic etiology? Can aortic stenosis be caused by rheumatic etiology? See, the common causes for aortic stenosis, one is age-related degeneration. Second is, the most common cause is age-related degeneration. Second is bicuspid aortic valve, right? Second most common is bicuspid aortic valve. And in case of rheumatic heart disease, it is extremely rare. You have to remember that aortic valve involvement is rare and isolated aortic valve involvement doesn't occur. If you have aortic stenosis, there will be mitral valve involvement for sure in the form of MS with or without MR, right? So this picture does not fit into a rheumatic etiology. So if I tell that this patient has atrial fibrillation, the best option I would choose is using anticoagulation with newer oral anticoagulants. Okay, and if I mention that he also had a mitral stenosis, then you have to choose vitamin K antagonist and your antiplatelets. Okay, I hope that is clear. Now let's move to the next question. Lance's sign on JVP is seen in which of the following conditions? Lance's sign. Options are, you have tricuspid regurgitation, tricuspid stenosis, cardiac tamponade and restrictive cardiomyopathy. Okay, have you heard of this thing called as Lance's sign? I know some of you recognize what is this Lance's sign, but you don't know the name. So if I tell you what exactly I'm talking about, you will be able to answer, but before that make an attempt if you can answer. Okay. Gautam Surisetti, yes, if it is with MS, that means that patient has mostly a rheumatic etiology, and yes, in that case, as of now, we have to go ahead with warfarin, because right now we don't have a study comparing newer oral anticoagulants and warfarin head-on-head in rheumatic heart disease patients. Non-rheumatic valvular disease, we have studies where they have compared newer oral anticoagulants and vitamin K, and NOACs are better. Okay, so the Lance's sign is also called as fused CV wave. Fused CV wave. So in which condition you see fused CV wave? JVP pata hai na, there is a C wave and a V wave, both of them are fused. In which condition we see that? Okay, Dharmesh Maheshwari and Debajit Saha say it is A, tricuspid regurgitation. Right, awesome, good. That's the correct answer. It is tricuspid regurgitation. So please remember, Lance's sign is nothing but fused CV wave. All of you are aware of fused CV wave, but you should know that the name is Lance's sign. Okay. Why there is fusion of CV wave in tricuspid regurgitation? Okay. What causes A wave in the JVP, right? So you have a first positive upstroke, which you call as A wave, right? This is your A wave. What causes A wave in the JVP? And tell me, A wave is occurring in ventricular systole or ventricular diastole? It is occurring in ventricular systole or ventricular diastole? Okay, let us talk about JVP, starting from a point where your left atrium has received blood from the left atrium has received blood from superior and inferior vena cava. From superior and inferior vena cava, it is received blood. So all this receiving of the blood has happened during ventricular diastole, right? Then the tricuspid valve opens and this blood moves from the left atrium to the right atrium to right ventricle, right? It is moving from right atrium to right ventricle. Initial movement of this blood is passive, right? Because the right atrium is not actively contracting. As soon as the valve opened, the pressure in the right atrium is more than the pressure in the right ventricle. So there is a passive movement of blood. Initially it fills. As soon as valve opened, gravity is also helping, the blood moves from RA to RV. But at some point of time, pressure in the RA and the RV becomes equal. At this point of time, the right atrium need to do this extra contraction, right? It is called as atrial kick. Atria does this extra contraction to push the remaining blood against this pressure gradient into the right ventricle, right? That atrial contraction, that active contraction is the one which is responsible for the A wave. Because what is JVP? It is a pressure that we are measuring somewhere in the jugular vein, which is indirectly representing right atrial pressure. So when right atrium starts contracting, pressure in the jugular vein will obviously increase. So that gives rise to your A wave. Okay. Now the blood from the RA is completely moved to RV. So the right atrium is almost empty. Now it starts relaxing. It is now getting into the diastole. It starts relaxing to receive the blood from superior vena cava and inferior vena cava. So this relaxation right now is happening with a closed tricuspid valve. Okay, so pressure in the atrial chamber is dropping down. So that gives rise to your next wave, which you call as X descent, right? You call this as X descent. Now, when this X descent is happening, right, the right ventricle is not keeping quiet. It is contracting. It is in systole. Atria is in diastole, relaxing and receiving the blood from superior inferior vena cava. But the right ventricle is contracting. So what is the first phase of right ventricular contraction? It is again isovolumetric contraction. So during isovolumetric contraction, both the valves are closed. This and this is closed. Right ventricle is contracting. So inside the right ventricle, pressure builds up. Okay. Then during this right ventricular contraction, isovolumetric contraction particularly, will there be a pressure on the tricuspid valve? Yes, because the pulmonic valve is not open, blood is not escaping, so the pressure will also be exerted on the tricuspid valve. So this tricuspid valve bulges into your right atrium. So if the valve is bulging into the right atrium, what will happen to the right ventricular pressure? It will slightly take a upwind. It is relaxing, but suddenly valve came into its cavity. So the pressure in the right atrium will increase. So that gives rise to another positive small upstroke. What do we call that as? In between this X descent, somewhere you will get a small positive upstroke, which you can call as, what do you call that as? What do you call that as? So your X descent can be divided into X and X dash descent. So this bulging of the tricuspid valve, right, this has led to a C wave. C wave. Okay. The bulging will not persist because once this pulmonic valve opens and the blood starts escaping into the pulmonary artery, right, the pressure on the tricuspid valve comes down, and thus the X descent continues after that. So it is a very momentary pressure. That's why you have small upstroke interspersed on the X descent. So that's why we have X and X dash descent, right? So that much is clear. A wave is because of atrial contraction. C wave, simply remember C for cusp bulge, tricuspid bulge into right atrium, and X continues as the X dash descent. Okay. Now the ventricular systole, this was happening. Now atria is receiving blood from the superior and inferior vena cava, right? IVC and SVC, it is receiving blood. So blood atria is getting filled. What will happen to the pressure in the atria now? The pressure will start going up, right? What that leads to? What will that leads to? Filling of the right atrium. So this is what we call as venous filling, right? So this is leading to another positive wave, which is called as V wave. Again, easy to remember. V stands for venous filling, simple, right? Venous filling. So superior vena cava and inferior vena cava are filling the right atrium. So right atrium is getting filled with blood. That gives rise to a positive V wave. Okay. After that, once the right atrium is filled with blood, now it's time for the ventricular diastole to begin. So the tricuspid valve opens. tricuspid valve opens, and as I told you, initial movement is passive filling, right? So this blood passively starts moving. Right atrium is not contracting, passively starts moving towards the right ventricle. So what will happen to the pressures inside the right atrium? It will drop down, right? So this leads to the next wave, which is negative, which you call as Y descent, because pressure in the right atrium is dropping down. That leads to Y descent. Okay. At the end of Y descent, there is little bit of blood left in the right atrium because the pressure between these two had equalized. Right atrium contracts again, giving rise to your next A wave. Okay, so this is your JVP. Now tell me what happens in tricuspid regurgitation. What happens in tricuspid regurgitation? Tricuspid regurgitation is happening in systole or diastole? Ventricular systole or diastole? Okay, when the ventricular systole began, right? When the ventricular systole began, we expected that this tricuspid valve would be closed. Initially, isovolumetric contraction period, the tricuspid valve will be closed, pulmonic valve will be closed. This is the starting point of your ventricular systole. Okay. Now, this pressure is being exerted, right, during the ventricular systole on both the valves. We are expecting that only pulmonic valve will open because of this pressure and the blood will move to pulmonary artery. But in the regurgitant tricuspid valve, unfortunately, as soon as this isovolumetric contraction starts, the the tricuspid valve doesn't hold back. It allows the regurgitation because it did not close properly. So the blood is now entering into the right atrium. It is going into the pulmonary artery also as the pulmonary valve opens, but some amount of blood is going into the right atrium also, right? So as soon as the tricuspid bulge occurred, after that this valve opened, right? So the blood started moving into the right atrium. So this X dash descent that was continuing, it will not happen because the blood is coming to right atrium. So the right atrial pressure will increase, right? Right atrial pressure will increase. So this C wave continues on to a V wave. C wave continues on to V wave without this X dash descent. That is what we call as fused CV wave. Okay, and this is seen in tricuspid regurgitation, TR. So remember always, tricuspid regurgitation is a systolic anomaly. During the ventricular systole, the blood is regurgitating into the right atrium. Tricuspid stenosis is a diastolic anomaly. During the ventricular diastole, when the right atrial blood should be moving into the right ventricle, because of this narrow valve, it finds it difficult, right? Same thing you can apply to the mitral stenosis and regurgitation. Okay, so the answer is clear. It is tricuspid regurgitation. Okay, now let's move to the next question. Again, this is bit of conceptual, so please just pay attention. These are the kind of questions where we do a lot of mistakes. In this question, we have a 35-year-old young, right, with a past medical history of diabetes mellitus type 2. He has presented for a follow-up. He states that he is feeling well and he exercises daily. So he is doing good. Okay. He is a non-smoker. He is currently taking metformin 500 milligrams twice daily and lisinopril 10 milligram once daily. Those are two of his medications. His blood pressure is 128 by 74 millimeters of mercury. His BMI is 22 kilograms per meter square. And his HbA1c is 7.2%. And his LDL is 100. Which of the following will help decrease his risk of cardiovascular disease or mortality? See, what are his problems? Let me list his problems. He has type 2 diabetes mellitus. Okay. General advice for a type 2 diabetes mellitus patient is look after your diet. Do at least 150 minutes of aerobic activities per week, which seems like he's doing, right? He's not a smoker. He is exercising daily. For a type 2 diabetic patient, I think the starting point would be metformin. He is receiving it. And lisinopril for his hypertension. Okay, that's a good choice in a diabetic patient because it reduces the risk of diabetic nephropathy, right? So I wouldn't consider it as a bad choice. His BP is 128 by 74. His hemoglobin is 7. HbA1c is 7.2%. His LDL is 100. Okay. Will increasing the lisinopril dose will reduce his cardiovascular mortality, or adding atorvastatin will reduce his cardiovascular mortality, or increasing the metformin dose will reduce his cardiovascular mortality, or adding insulin? Which one will reduce his CV mortality? What can prevent him from dying because of a coronary vascular event? Okay, Sujit Mayangbam says more than 70% in DM. Okay, anybody has a different view on this? Okay, So let us address one by one. Let us address one by one. Okay, point number one. The easy meeting is exercise goals. What is the recommendation for exercise in a type 2 diabetes mellitus patient? Right, a minimum of 150 minutes of modest aerobic activity, right? Moderate aerobic activity, minimum of 150 minutes. That means like 30 minutes for 5 days a week. That would be like adequate to say that he is exercising properly. So exercise goal, though they have not mentioned details, I will assume that he is doing it. Okay. Then what is the BP target for a diabetic patient? What is the recommended BP cutoff, BP target? Yeah, brisk walk or any other equivalent activities which can be considered as moderate intensity aerobics, not the mild intensity and not those cardio exercises that weight loss aspirants do. Those are not standardly recommended. Yes, 150 minutes per week. Yes, fine. Okay, BP cutoff. Most of the current guidelines recommended BP should be kept less than 130 by 80. Okay, easy meeting his target. Fair. Okay, so do we need to tamper his diabetic medications? Probably no, right? I would still consider giving a 2-drug combination because mostly current guidelines recommend that we should be giving, instead of like giving a lisinopril 10 milligrams, I can give 5 milligram lisopin and another calcium channel blocker. So current recommendation is 2-drug regimens using a CCB plus a ACE inhibitor or ARB. These are recommended because see, I want the benefits of ACE inhibitors or ARBs, but when I use or depend on a single drug to control BP, there is a chance that I will be achieving that control of the BP with some side effects of the drug. So when we combine 2 drugs, we are trying to act through 2 different mechanisms. So we will be able to use 2 drugs at lower doses. The side effect risk is reduced. So it is recommended because option doesn't talk anything about an antihypertensive medicine. So I'm not thinking about it. So BP target is met. So let me keep it that way. Okay. His BMI is fairly acceptable. He is not in the overweight category. Fairly acceptable, right? Okay. Is his HbA1c acceptable? Is his HbA1c acceptable? Is his HbA1c acceptable? What is the recommended HbA1c cutoff or target? What is the HbA1c target for a diabetic patient? Okay, so there are 2 recommendations I want you to remember. HbA1c target. Okay, what most of us follow is American Diabetes Association, and that recommends that it should be kept less than 7. It should be kept less than 7 in a diabetic individual. Okay, for diagnosis of diabetes, if it is more than 6.5, it is diagnosed as diabetes. Once you start treating, we should maintain it under 7. And there is also an American College of Endocrinology, ACE, that recommends that we should keep it less than 6.5. Regardless of whatever guideline you follow, there is Indian own guidelines which also recommend 7. Regardless of whatever guidelines we follow, is his HbA1c acceptable to us right now? No. Right? Now, between these 2 risk factors, LDL and HbA1c, which one has a major impact on the stroke outcome? Is dyslipidemia a strong risk factor for stroke, or is it uncontrolled diabetes a strong risk factor for stroke? Okay, remember, among the medical diseases, forget about atrial fibrillation, a clot in the left atrium and all, those are really potential risk factors. Carotid artery stenosis, those are potential risk factors. But among the medical disorders that we routinely manage, diabetes is the strongest risk factor. It is much more stronger a risk factor than dyslipidemia. Okay, because it accelerates atherogenesis much faster than just the dyslipidemia. So if you have to ask me to choose between 2, what you would manage first, it is good glycemic control. And remember, this dyslipidemia is also partially because of insulin resistance. So if you achieve a good glycemic control, dyslipidemia proportionately might show some improvement. So the priority here is to get the HbA1c less than 7, right? Okay. With respect to LDL guidelines, LDL, there are different guidelines and they have different stance on the management of LDL. Largely remember, less than 100 is acceptable. LDL less than 100 is acceptable in people with high risks. In people with high risk, like in this case, diabetes mellitus, right? You can aim for less than 70. You can aim for less than 70 if it is possible to achieve. but less than 100 is acceptable. Less than 100 is acceptable. So I would accept this lipoprotein, and I'll also see if his exercise improves, if his glycemic control improves, how much improvement I will see in the lipoprotein LDL levels, and then I will decide if I need to add. Okay, should we add a statin empirically for a diabetic patient? Like, should we start statin for all diabetic patients? The answer is no. The answer is no. There is a recommendation which says that if the patient has 5 years history of diabetes, type 2 diabetes especially, type 2 diabetes mellitus for 5 years, or his age is more than 40, if age is more than 40, then you can empirically initiate the statins even if the cholesterols are normal to reduce the stroke risk. But now his age is just 35, so probably we don't need, right? Okay, if you are thinking that at 35 who is developing type 2 diabetes mellitus, then come to OPD and you will see a lot of 35s have type 2 diabetes mellitus now. Okay, so what makes the logical choice here? Increase the metformin dose, because are we giving metformin at the appropriate dose or the peak dose? No, right? We are giving 500 twice a day. You can go up to 2.5 to 3 grams. Right, so most of us give for 2 grams. You can go up to 2.5 to 3 grams depending on patient's weight and the renal parameters. Because this patient's renal parameters are not given, I will assume he's doing well. So we can comfortably increase the metformin dose. Okay. If you ask me what is the next best thing we can do to reduce this cardiovascular mortality, the next best thing would be to add atorvastatin. Okay, good. Let's move to the next question now. Okay, very simple, but I know most of you might pick up a wrong answer. A 42-year-old from Nashik, diagnosed with duodenal ulcer, okay, and his biopsy specimen is positive for urease. Okay, so what does that indicate when you have someone who has a duodenal ulcer and his biopsy specimen is positive for urease? What does that indicate? We all know it indicates H. pylori infection, right? H. pylori infection. Now, which of the following is appropriate prescription for him? There are 4 regimens mentioned: lansoprazole, amoxicillin and clarithromycin, metronidazole, clarithromycin and pantoprazole, bismuth subcitrate, pantoprazole, metronidazole and tetracycline, levofloxacin, omeprazole, nitazoxanide and doxycycline. Okay, Dr. Sanju Hazra says option C. Yes, we have H. pylori infection. It needs to be eradicated, right? Because it is associated with ulcer progression, increased risk of malignancies, vitamin B12 deficiency and atrophic gastritis and various other outcomes. Even there are studies which show that H. pylori is associated with osteoporosis. Okay, so there are different types of H. pylori regimens, right? Few points we should know is there is a triple drug regimen, quadruple regimen, there is sequential regimen, right? And then you also have, you also need to know the duration of treatment. So let us address one. What is the duration of antibiotic treatment recommended? Duration of treatment. How many days you will give this antibiotic combination? How many days you will give antibiotics? 1 week, 10 days, 14 days. How many days you will give this combination? You should know, right? You only knowing the regimen is not adequate. Yes, 10 to 14 days. And in the context of India, what is recommended is that we should be giving for 14 days. We should be giving for 14 days in India. Because no, like our patients are already exposed to so many antibiotics left, right, center for whatever indications, even for cold. So we need a little longer duration. So in India, it is recommended that 14 days. Okay. And you have to remember that there are antibiotics which H. pylori has developed potent resistance, right? So what are the antibiotics which we are concerned about resistance? There is very high incidence of macrolide resistance among H. pylori. So in the Western world, what they do is they test, or they know that the local prevalence of macrolide resistance, if it is more than 15%, then they don't use any regimen which contains a macrolide, azithromycin or clarithromycin. They are dumped, right? So there is high clarithromycin resistance. Simple, na? It is expected because for simple cold also we give azithromycin. So macrolides will be anyway resistant. Second, there is very high incidence of metronidazole resistance. Metronidazole resistance. Okay. So Western world, they see whether the macrolide resistance locally prevalent is high. If high, they will choose a regimen, triple drug regimen, which does not have clarithromycin. Okay. But in India, there is an association called as Indian Association of Gastroenterologists, which recommends that because of the prevalent resistance patterns, we have to start with a quadruple regimen. This is from 2020. Recommendation is Indian Association of Gastroenterology recommendation is quadruple regimen only and 14 days only. Quadruple regimen only and 14 days only. Because clarithromycin resistance prevalence is extremely high. In a city called Mumbai, it is close to 100%. So H. pylori, almost 100% of the isolants are resistant to clarithromycin. Even in Bangalore, it is 30-40% plus. The recommendation is 15% ke upar hai, so you should not use any clarithromycin based, right? Okay, now you might question me, sir, you said metronidazole is also high, but when we use this combination, right, with tetracycline, the metronidazole resistance can be overcome. Sanjit, mind bump, right now we shouldn't be giving the HP kit because it is highly resistant. And there is another problem in Indian practice. Once you give HP kit, no, for 14 days, your story does not end there. After 14 days, you will continue with PPIs. So PPI component will be continued. What is the total duration of PPI for a patient with the peptic ulcer? 4 to 8 weeks. Again, we prefer 8 weeks to facilitate complete healing. At the end of 8 weeks, you need to give 2 weeks of gap and then retest for H. pylori eradication. Only when that retest comes negative, you have done your job. In India, we just give an HP kit for 10 days or 14 days and forget after that. But many patients continue to have H. pylori. Okay, so please remember that. And they might ask you, what is the investigation of choice for retesting? Here, though endoscopy was done, they did the urease test. Fair enough. For the confirmatory test, like for eradication confirmation, what is the test preferred? How do you prove that it is eradicated? Will you ask him to come back and do another endoscopy and do a urease test on the endoscopy specimen? Or you will do a urea breath test? See, first time when he came, we had to make a diagnosis of the peptic ulcer, right? So we had to do an endoscopy. Jab ulcer dekha, biopsy liya, done. But when he comes for second time for follow-up, we cannot go ahead with an invasive test, right? He will also not agree. So the investigation of choice for eradication is urea breath test. Okay, let me write it down here. Investigation of choice for H. pylori eradication is urea breath test. Is urea breath test, which is a non-invasive test. The serology is only done, the blood test serology against like antibodies against the H. pylori is only done for the mass screening purpose. When you have epidemiological studies to understand prevalence of H. pylori infection in a given society, like you go to a slum and you want to know what is the prevalence of H. pylori infection there, it is very cumbersome to do urea breath test for all of the patients. It is very impossible, or it is also inhuman to subject everyone for endoscopy and biopsy when they don't have any symptoms. So rather you can go for serology. So serology or blood tests are mainly reserved for epidemiological studies where you want to understand the prevalence. Initially, for the initial diagnosis, best test is the biopsy specimen urease test, because anyway you need to do an endoscopy for ulcer diagnosis, and for eradication it is a urea breath test. Okay, good. So please remember, quadruple test which contains bismuth is currently recommended. Quadruple regimen containing a bismuth is currently recommended. You can simply remember it as PBMT or OBMT. There are like commonly available regimens are OBMT and PBMT. So O here is omeprazole, B here is bismuth, M is metronidazole, T is tetracycline. Okay, and also you need to remember one more regimen called as load regimen. They might ask you the components of this, right? Can anybody tell me the components of load regimen? Components. L, I will tell you, it is levofloxacin. L is levofloxacin. Yeah, the rifabutin based triple, and there is also a high dose amoxicillin dual, amoxicillin high dose plus the PPI. Those regimens are reserved, like when this patient comes back for follow-up, you do a eradication test. Okay, urea breath test is negative, you've done your job, good. Urea breath test is still positive, then you need those rescue regimens. So rifabutin based triple and high dose amoxicillin dual are reserved regimens when the quadruple fails to eradicate the infection. Okay. Okay, so load regimen ka first component is levofloxacin, which can be considered as an alternative to OBMT, but mostly we follow OBMT. Okay, second one is omeprazole. Okay, the fourth one is doxycycline. There was an MCQ in INI asking which of the following is not a component of load regimen. What A stands for? A is not amoxicillin. Okay, all the people picked up D as wrong. Some of them thought it is domperidone or something like that. D is doxycycline. A is not amoxicillin. A is what? A is nitazoxanide. A is nitazoxanide. A is nitazoxanide, whose brand name is Alina. Alina is a brand name of nitazoxanide. So brand name was used in this regimen. to make it easy to remember or reproduce. Though they use the brand name of this nitazoxanide, Alina. That's how it became load. But A is not amoxicillin, so please don't do that mistake in the exam. Okay, it's not azithromycin either. It is nitazoxanide. Okay. Now coming to the next question. Which of the following is not a common cause for atrial fibrillation? I think you would have got some idea about atrial fibrillation from previous two questions that we discussed. Now tell me which of the following is not a common cause for atrial fibrillation. Options are mitral regurgitation, hypothyroidism, hypertension, and acute myocardial infarction. Devi Jyoti Sahar, right? Yes, it is nitazoxanide. Which of this is not a common cause for atrial fibrillation? Anybody is giving an answer? Okay, let us go one by one. Okay, can mitral regurgitation be associated with atrial fibrillation? Can mitral regurgitation be associated with atrial fibrillation? MR can be associated, right? We just discussed the pathophysiology that when there is mitral regurgitation, during the left ventricular systole, mitral valve fails to keep itself closed. Our expectation is that during left ventricular systole, the aortic valve will open and the blood will move from LV to aorta. But because this mitral valve failed to close, blood will now also go into left atrium. So that increases the left atrial burden and left atrium becomes enlarged. So in mitral regurgitation also you will see left atrial enlargement. So once the left atrium is enlarged, there is risk for atrial fibrillation. So mitral regurgitation can cause atrial fibrillation. Okay. Then can hypertension cause atrial fibrillation? The answer is big yes. Hypertension is the most common risk factor for atrial fibrillation. Various hypotheses or mechanisms. Simple thing you can remember is in hypertension, left ventricular hypertrophy develops. Once the left ventricular hypertrophy develops, left ventricular relaxation is affected. So the emptying of blood from mitral valve to left ventricle, from left atrium to left ventricle is now impaired. So left atrium will start slowly enlarging. So hypertension can be, left ventricular hypertrophy can be a cause for left atrial hypertrophy, and thus hypertension can be a cause for atrial fibrillation. Okay. Myocardial infarction, yes, it can be associated with atrial fibrillation. See, the most common ECG arrhythmia that you see in myocardial infarction is generally sinus tachycardia. Apart from the typical MI ECG changes, you will see sinus tachycardia. You can have ventricular arrhythmia, but even atrial fibrillation can occur. Okay, so MI, please remember that it is one of the common abnormalities. After VT, this is like a short run of VT, next is atrial fibrillation only. It can occur. Can hypothyroidism be associated with atrial fibrillation, or hyperthyroidism is associated with atrial fibrillation? Which one is associated with, right? Hyperthyroidism is classically associated with atrial fibrillation. Hypothyroidism is not associated with atrial fibrillation. So we have to remember this. Hyperthyroidism is an important risk factor for atrial fibrillation. Okay, there are 2 points you need to address about atrial fibrillation and hyperthyroidism. If you have atrial fibrillation which is caused by hyperthyroidism, will you give him the antiarrhythmic drugs or not? Will you give this patient antiarrhythmic drugs or not? Will you give a hyperthyroid patient with atrial fibrillation antiarrhythmic drugs are given or not? What is the most commonly used antiarrhythmic drugs for atrial fibrillation? You have a patient with atrial fibrillation. If he is hemodynamically stable, you are giving him pharmacotherapy, right? You are trying to control his rate, giving beta blockers and all, and you are trying to set the rhythm back to normal sinus rhythm by giving antiarrhythmics. The drug that we use is amiodarone. Okay, is amiodarone good for your thyroid? Is amiodarone good for your thyroid? No, right? Amiodarone has rich iodine content in it, and amiodarone can cause both hypo as well as hyperthyroidism. So it can worsen his hyperthyroidism. We should not be giving it, right? So hyperthyroidism, and you have to remember that more than 50% of atrial fibrillation patients revert to sinus once euthyroid is achieved, euthyroid status is achieved. So if you just treat his hyperthyroidism and his TSH comes back to normal, right, and his T4 drops down to normal, more than half of the patients atrial fibrillation will automatically reverse. Only those patients where it is not reverting, you will think of pharmacotherapy and you will not be touching the amiodarone, right? Amiodarone is not a choice. You can use that verapamil or other drugs. Okay, clear? That is one point. Second, will you anticoagulate? Will you anticoagulate? Should we anticoagulate a hyperthyroid patient developing atrial fibrillation? The answer is yes, but no. Means it depends on CHA2 DS2 VAS score. The score recommends that you should give anticoagulation depending on patient's his risk. Give. If it recommends that there is no risk of embolism, then you don't need to give. Right? It's as simple as that. So it is totally dependent on CHA2 DS2 VAS score. Okay. There are only few conditions where a case of atrial fibrillation is anticoagulated irrespective of CHA2 DS2 VAS score. Okay, one of that is whenever you have a rheumatic valvular pathology leading to atrial fibrillation, like mitral stenosis, mitral regurgitation, atrial fibrillation, don't look at CHA2 VAS score. Just give anticoagulation. देखना ही नहीं है, calculate करना ही नहीं है. Second is when you have hypertrophic cardiomyopathy, HCM, they are also at risk of atrial fibrillation. Same concept. HCM is nothing but left ventricular hypertrophy, right? So left atrium gets affected. There is a very high risk of stroke. So those patients also, you should not look at CHA2 VAS score. Start anticoagulation just like that. Echo shows HCM, atrial fibrillation hai, anticoagulation karna hai. In all other conditions, including hyperthyroidism, you will decide whether to give or not based on CHA2 DS2 VAS score. Okay, cool. So in this case, hypothyroidism is not known to cause. What ECG abnormalities hypothyroidism can cause? Hypothyroidism can often be associated with pericardial effusion. Okay, so you can have low voltage complexes on ECG. Low voltage complexes. Hypothyroidism can be associated with heart blocks, not tachyarrhythmias. Tachyarrhythmias are typically associated with hyperthyroidism, right? Like thyroid hormone goes up, it is increasing the BMR, metabolic milieu is all pumped up. So tachyarrhythmias are common with hyper. Bradyarrhythmias are common with hypothyroidism. You can also develop sinus bradycardia. One of the clinical manifestation of hypothyroidism is you have bradycardia. Okay. Now coming to the next question. All of the following are causes for exudative pleural effusion except. They are asking which of this is not a cause for exudative pleural effusion. Options are superior vena cava obstruction, fungal infection, SLE and Meek syndrome. Which of this is not a cause for exudative pleural effusion? Okay, I'll be waiting for your answer because this is one of the very basic question. Aapke final MBBS bedside discussion maybe they will ask this. Viva OSCE, instruments, हर जगह they will ask exudative versus transudative pleural effusion. Okay, हम कैसे differentiate करते हैं exudative versus transudative? Differentiation के लिए what the criteria we use? Criteria that we use? The criteria is called as Light's criteria, right? Light's criteria. So there are three components of Light's criteria. You do a pleural fluid analysis, and if first thing is if your pleural fluid bar serum protein ratio, pleural fluid bar serum protein ratio, if it is more than or equal to 0.5, or pleural fluid by serum LDH ratio, right? Pleural fluid LDH and serum LDH, pleural fluid protein and serum protein ratio. If that is more than or equal to 0.6, and the third one is if your pleural fluid LDH levels are more than 2/3 of the serum LDH levels, or more than 2/3 of the upper limit of normal, even that. Okay, so all of this would categorize the fluid as exudative. Okay, exudative fluid in terms of its composition is more close to plasma, and the transudative fluid in terms of its composition has less protein, less LDH, less inflammatory cells. So it is more close to, I can say, water, right? It is more like water if it is transudative. It is more like the plasma composition if it is exudative. Okay, exudative is mostly because of the inflammation of the pleura from where the pleural fluid is leaking. Okay, so can fungal infection of the lungs or pleura, can it cause inflammation? Yes, so it will mostly cause exudative, right? Any pneumonia, fungal, viral, bacterial, it can be associated with an exudative effusion, right? Okay, in SLE, why pleural effusion is occurring? SLE, rheumatoid arthritis, systemic sclerosis, all of them cause what is called as serositis. That means all the serosal lining, pleura, pericardium, peritoneum, they can get inflamed. So whenever they're inflamed, they'll leak the fluid because there is capillary injury. So when they're leaking the fluid, they're leaking plasma. So the composition is close to plasma. That's why it looks like exudative. So SLE causes inflammatory pleuritis, and that leads to pleural effusion. So that is also going to be exudative. Okay, what is Meeks syndrome? What is Meeks syndrome? गायनकोलॉजी से मेडिसिन का कनेक्ट होता है मीक सिंड्रोम में, राइट? व्हाट इज मीक सिंड्रोम? Ovarian fibroma associated with ascites and pleural effusion, right? That also is going to be exudative. Why effusion is occurring in SVC obstruction? In SVC obstruction, the effusion is occurring because of the rise in the superior vena cava is obstructed, right? So the blood is getting diverted into other thoracic veins. So the pressure, hydrostatic pressure in the veins is increasing. So when the pressure increases, right, it draws out the fluid from the venous system into the pleural space, but it is drawing out the fluid, not with lot of proteins. It's the plain water that is getting drawn out mostly. So SVC obstruction will lead to transudative effusion. Can anybody give me the most common cause for transudative effusion? SVC, yes, the answer is right. So Sunjit, yes, ovarian fibroma, ascites, pleural effusion. That's your triad of Meeks syndrome. Triad of Meeks syndrome. Ovarian fibroma. Okay. Most common cause for transudative effusion. Right, awesome. Most common cause for transudative effusion is congestive cardiac failure or heart failure. That's the most common cause for transudative effusion. What is the most common cause for exudative effusion? Most common cause for exudative effusion. Most common cause for exudative effusion is paranpneumonic effusion or infection. Simple words, infection. Paranpneumonic effusion or infection. That's the most common cause. Okay, I want you to remember 2-3 important extra points about this paranpneumonic effusion, because these questions have been asked multiple times. Which one is transudative, which one is exudative? आपको पता है answer. You can logically also answer even if you're not gone through the Harrison table. Okay, but they will ask you sometimes that here is a patient with pneumonia, his cough, and there is consolidation on the X-ray, and he has developed the pleural effusion. We have tapped it. This is the report. Now, how do you manage? Should you do a complete drainage putting an ICD or just treat with antibiotics? Okay, so for that we have to remember tuberculosis obviously will cause exudative, right? Any infection will cause exudative effusion. So tuberculosis will obviously be exudative. Some extra points are there about tuberculosis. I'll tell you in a bit. Okay, so paranpneumonic effusions are basically, the term para means the effusion is happening parallel to pneumonia. You have a pneumonia, simultaneously there is effusion. So that's why you use the term paranpneumonic. Okay, paranpneumonic effusion is also called, or it's equal to synpneumonic effusion. Syn means simultaneously हो रहा है, para means parallelly हो रहा है, same, right? Paranpneumonic or synpneumonic effusion. Okay, so you have to remember that it is always exudative, and we classify them into simple, uncomplicated, simple or uncomplicated paranpneumonic effusion. Second is complicated, and the third one is empyema thoracis or empyema. How do you differentiate? For differentiation, we need to know 3 parameters. Okay, parameter number 1 is the pleural fluid. Pleural fluid pH, that's the first parameter, very, very important parameter. Second is pleural fluid glucose. Okay, and the third one is pleural fluid culture or gram stain Okay, so in case of the simple or uncomplicated, pleural fluid pH will be more than 7.2. Like lesser the pH means the bacterial metabolism is very active there. So bacteria are there in the fluid. It's not that pneumonia just caused the inflammation and the fluid is seeped into the pleural cavity. Bacteria are there in the pleural cavity when the pH is less than 7.2. So in case of simple or uncomplicated, it is just the the parietal visceral pleural inflammation has led to effusion. Okay, so pH will be more than 7.2. And the pleural fluid glucose, lesser the glucose, that means there are bacteria which are taking it up for their metabolism, right? So here it should be more than 60 milligrams per deciliter. Okay, and the culture or gram stain should be negative. Then you will call it as simple. It is exudative according to Light's criteria, but when you look at pH, it is more than 7.2, glucose is not low, and culture and pleural fluid gram stains are negative. That is your simple or uncomplicated parapneumonic or sympneumonic effusion. When do you call it as complicated? Any one of these three parameters I described, if they are abnormal, right? Any one of the three parameters I described, if it is abnormal, that can be called as complicated. When it is less than 7.2 in terms of pH, or if the glucose is less than 60 milligrams per deciliter, or culture or gram stain, any of that is positive. Any one is also enough to call it as complicated. Okay, clear? So if I give you a the pleural fluid report, Light's criteria, exudative, and then I will mention that the pleural fluid pH is less than 7.2, then it is complicated. Or pH, I will tell you that it is 7.2 plus, but glucose is less than 60, complicated. Okay, or pH is more than 7.2, glucose is more than 60, but the gram stain or culture is positive, complicated. Okay, then what is empyema? Empyema is nothing but complicated parapneumonic effusion with frank pus. So when you tap it, you're not just getting the cloudy fluid, but you're getting frank pus. When you tap, you're clearly seeing that it is pus, not fluid. That is what we call as empyema. So empyema is the subset of complicated parapneumonic effusion, right? So if it is simple, treat pneumonia, that's it you need to do, right? You don't need to do anything specific for this fluid. Treat pneumonia, the fluid will resolve. But if it is complicated or empyema thoracis, we need to go for ICD insertion and complete drainage in addition to antibiotics. ICD insertion till complete drainage plus antibiotics to treat the pneumonia plus antibiotics. Okay, so based on the circumstance, you should be able to answer these kind of questions. Pneumonia, uncomplicated, option is only antibiotics. Complicated or empyema thoracis, depending on the parameters I just told you, ICD insertion is recommended. Okay, that's about this question. Someone was asking about tuberculosis, right? Okay, first point you also need to remember is the pleural effusion where the glucose is less than 60. Pleural effusion with pleural fluid glucose less than 60. I want you to remember important causes: less than 60 milligrams per deciliter. Three important causes. First one is, obviously we have learned about it, complicated parapneumonic effusions or pneumonia associated. Second one is rheumatoid arthritis, right? This is repeatedly asked question. Rheumatoid arthritis, what happens to the glucose level? It is less than 60. And the third one is malignancy. When there is pleural malignancy or metastasis to the pleura, malignancy associated pleural effusion, also glucose will be less than 60. Okay, then about tubercular pleural effusion. Okay, first question that they can ask you is, can you do a CBNAT? Can we do a CBNAT for the diagnosis of tubercular pleural effusion? CBNAT pata hai na, cartridge based nucleic acid amplification test. Can we do a CBNAT for diagnosis of pleural effusion, or the PCR of tuberculosis from the pleural fluid? Can we do it? Can we do it? And what is the gold standard for diagnosis of pleural tuberculosis? Two important MCQ point. Okay, so CBNAT, you do CBNAT or TB PCR in your CSF fluid, you do it from various other fluids, but not in pleural. Not in pleural, right? Sputum you do it, that's like a standard thing now, but not in pleural. Why? Because the pleural tuberculosis is paucibacillary and mostly it will not give rise to a positive result. Its sensitivity is only 40%, right? CBNAT in pleural fluid, so please remember, not recommended. Not recommended. Don't even send it. भेज रहे हो तो you are burdening the system and you are unnecessarily costing the patient. Not recommended, because pleural TB is paucibacillary, so you will not get good result, right? 40% sensitivity, which is not adequate, right? So gold standard for pleural tuberculosis diagnosis is pleural biopsy. Pleural biopsy. Pleural biopsy is the gold standard because in the fluid not many bacilli are there, so your CB0 will come negative. Take the pleura and do the biopsy. Okay, but we can get some surrogate clues, right? Most of the times when there is tubercular effusion, there will also be involvement of the lung, and that will be evident on the X-ray or CT thorax. Second, you can look at the ADA levels. Pleural fluid ADA levels more than 40 is highly sensitive in the right clinical context. Patient symptoms are all resembling tuberculosis. Pleural effusion is there. We tap it. ADA is more than 40. It is also highly sensitive. It is way more sensitive than doing your TrueNAT or CBNAT. Okay, so it is not recommended. There was a question in the previous NEET asking the CBNAT is not recommended in which of the following circumstances, and one of that was pleural effusion. Okay, good. Now coming to the next question. All of the following can cause hyperprolactinemia except craniopharyngioma, hyperthyroidism, stress, and chronic renal failure. Hyperprolactinemia. So we're talking about an endocrine condition. Prolactin levels are high. Which of this can cause or which of this cannot cause? Yeah, pleural fluid cultures might yield you some decent results, but they're obviously time consuming. So that's what not we practice. If you have this right context, no, patient's history suggestive of tuberculosis, pleural effusion is there in a country like India, ADA more than 40 is kind of adequate to consider it as pleural tuberculosis and start treating. Okay. Okay. So what are the common causes for hyperprolactinemia? Physiological causes are there for hyperprolactinemia, right? The stimulation of the nipple, pregnancy, these are all physiological causes. Exercise, these are physiological causes. Okay. Even stress can cause hyperprolactinemia. Okay. But there are pathological causes. Important causes we need to remember is prolactinoma, right? Prolactinoma is obviously an important cause for hyperprolactinemia. Agreed? Okay. Even when the pituitary stalk gets compressed or it gets injured, okay, you can have hyperprolactinemia. Why that is happening here? See, when you look at the pituitary gland, no? When you look at the pituitary gland, it is under the hypothalamic control. Every other pituitary hormone, you talk about TSH, you talk about ACTH, every other anterior pituitary hormone, they are all positively stimulated by the hormones produced by the hypothalamus, right? For example, if I'm talking about TSH, TRH comes from the hypothalamus, which stimulates the anterior pituitary to produce TSH. So they are under the stimulatory control, right? TRH comes, it stimulates the anterior pituitary, then TSH is produced. But prolactin is one hormone which is under the inhibitory control, right? Hypothalamus constantly produces dopamine, right? And this dopamine will inhibit the prolactin secretion. It inhibits the prolactin secretion, right? It is under the inhibitory control. Now, if I cut the pituitary stalk, which is the connecting link between the hypothalamus and the pituitary gland, which hormone is going to increase and which hormones are going to decrease? All other hormones, because the hypothalamus to pituitary connection is cut, all other hormones are going to go down. TSH will go down, ACTH will go down, growth hormone will go down, FSH, LH will go down. But prolactin will increase because it was under the inhibitory control. You have taken off the inhibition. Now you have released the pituitary gland free, right? It will start producing lot of prolactin. So craniopharyngioma is a suprasellar tumor which can compress the pituitary stalk. It can compress the pituitary stalk and cause discommunication between the hypothalamus and the anterior pituitary gland. So craniopharyngioma is a well-established cause for hyperprolactinemia. Stress, nipple stimulation, exercise, these are all well-established physiological causes for hyperprolactinemia. Okay. Then you have to remember that both organ failure, liver as well as kidneys, they play a role in prolactin metabolism. Okay. The prolactin is fragmented into some peptides and that eventually gets cleared by renal elimination. So if you have chronic renal failure as well as CLD, in both cases the prolactin levels increase. In both cases prolactin level will be high. Okay. Now coming to this option, hyperthyroidism, can it be associated with hyperprolactinemia? Okay. I have to tell you how the thyroid gland is regulated. The hypothalamus produces a hormone called as TRH, right? Thyrotropin releasing hormone. This will come and at the thyroid gland, it will have a positive influence to produce TSH. Sorry, the pituitary gland. It will influence the pituitary gland to produce TSH, and the TSH will act on the thyroid gland to produce T3, T4. Okay, and these will have a feedback negative inhibition. TSH it will suppress, TRH it will suppress, right? Okay, but you have to remember that TRH not only stimulates the anterior pituitary to produce TSH, TRH also stimulates the production of prolactin, right? So TRH also stimulates prolactin production. So in any condition where TRH goes up, hyperprolactinemia can occur, right? Commonly hypothyroidism, what happens? T3 and T4 production is reduced. So that leads to increased TSH production, and that will also lead to increased TRH production. So hypothyroidism causes increased TRH production, primary hypothyroidism. So if TRH is going up, it can stimulate prolactin production. So hypothyroidism is associated with hyperprolactinemia. If there is hyperthyroidism, actually there will be TRH suppression, and that can cause reduced production of prolactin, right? So please remember, TRH stimulates two hormones. One is prolactin production and second one is TSH production. So whenever TRH goes low, prolactin production goes low, TRH increase, prolactin levels increase. TRH commonly increases in primary hypothyroidism. In hyperthyroidism, mostly it is suppressed. So hyperthyroidism, you are not expecting. Hyperprolactinemia occurs in hypothyroidism. So please remember that, hypothyroidism. हिंदी कोशिश करता हूँ, जितना टूटी फूटी मुझे आती है उसमें कोशिश करता हूँ, ठीक है? Okay, so this question is clear. Hypothyroidism is associated with hyperprolactinemia. I want you to remember this one point. And both organ failures, kidneys as well as liver, are associated with hyperprolactinemia. Okay. Now this question, I think you guys should be able to answer. The diagnosis of which of the following condition is done by renal angiography? Which of this we can diagnose by renal angiography? Do we need it? Can we diagnose polyarteritis nodosa by renal angiography, or Wegener's, or leukocytoclastic vasculitis, or microscopic polyangiitis? सौम्यदीप दास कोशिश करता हूँ जितना आता है मुझे. किसके लिए renal angiography would be adequate? Okay, see, Wegener's, leukocytoclastic vasculitis, microscopic polyangiitis, all of that require a renal biopsy. They would require renal biopsy or other tissue evidences. Okay, but polyarteritis nodosa, right? Few points I've already discussed in the previous session. It is a vasculitic condition, right? Now polyarteritis nodosa, what kind of vasculitis it is? Medium vessel vasculitis, small vessel vasculitis, or large vessel vasculitis? What kind of vasculitis it is? Medium vessel, small vessel, or large vessel? We have discussed this in the previous session also. Okay, so polyarteritis nodosa, you have to remember that it's a medium vessel vasculitis. It's a medium vessel vasculitis. Okay, it can be called as primary or secondary. Secondary is when it is associated with hepatitis B virus infection. Okay, and it is called primary when it has some genetic causes and no other infection association. ADA2 mutation is the most common cause. Okay, and here in this case the vasculitis lead to development of aneurysms of the vessels, aneurysms of the medium-sized arteries. And when we talk about aneurysms of the medium-sized arteries, there will be involvement of small, predominantly it is medium vessel vasculitis. When there is aneurysms of the arteries, they can ask you MCQ wise what is the most commonly affected artery and what is the artery that is generally, medium-sized artery that is generally spared. Okay, so this we have discussed in the previous session also. The most commonly involved artery is the renal artery. Okay, and I had told you that bifurcations, when renal artery is branching and those bifurcations ke beech mein there will be aneurysms. So you can diagnose polyarteritis nodosa by doing angiogram. Every other vasculitic condition that we discussed, we need a tissue biopsy. Okay, and last point to remember is the artery that is spared. This MCQ appeared in the last NEET PG. Which of the following artery is spared in case of the polyarteritis nodosa? So pulmonary artery is usually spared in case of polyarteritis nodosa. Okay, let me give you an image. Yeah, this is actually the angiogram, renal artery angiogram of a patient with polyarteritis nodosa. Okay, so you can probably see the kidney outline here, renal artery, and wherever the artery is bifurcating, right, wherever the artery is bifurcating, you are seeing aneurysms there. All these bead-like structures are aneurysms. If this image appears and they tell that the patient is having some renal dysfunction, your diagnosis is very clear, right? So there are aneurysms of the renal artery and its branches. This goes in favor of the diagnosis of polyarteritis nodosa. Okay, so the answer for this question is pretty straightforward. Only PAN can be diagnosed using the renal angiography. Okay, now let's move to the next question. Hypomemia is seen in which of these conditions? This is also one of the previous repeats. Hypomemia is seen in which of these following conditions? Okay, let me wait for the answers from you so that we can discuss a little bit about this hypomemia. Where do we see hypomemia? Where do we see hypomemia? Okay, Ravi Kiran thinks it's option A, multiple sclerosis. Okay, do you know what do I mean by hypomemia? Okay, you guys during your college fest do this miming act, right? Miming. What is miming? It's a kind of act where you're trying to communicate with expressions, right? Hypomemia means expressions have come down, right? In simple words, you can say reduced expressions. Where do you see reduced expressions? In these patients, in these four conditions, where you characteristically describe a mask-like face. It's called mask-like because expression नहीं है. John Abraham बन गया है बिल्कुल. Right? दर्द हो, खुशी हो, sad, happy, no expressions. Exactly, John Abraham. क्यों? Which condition it happens? Right? It happens in Parkinson's disease or Parkinsonism. It happens in Parkinsonism. Tell me why the expressions in patients with Parkinsonism are reduced. It's not because they're depressed. Yeah, depression hota hai Parkinson disease mein because major disease have difficulty with lifestyle, so they have depression, but that's not the reason why they have mask-like faces, why their expressions are not there. Okay, how do you describe Parkinson disease? Parkinson disease or Parkinsonism, let me call Parkinson disease only. Parkinson disease, we broadly describe it under a broad heading called as akinetic rigid syndrome. Akinetic rigid syndrome. Okay, under this there are so many conditions. Parkinson disease is one of them. So it has some characteristic things. There is akinesis, there is rigidity, plus there is a third component which is very characteristic of Parkinson disease, which is tremor. So there are three things which come together to make a patient as having Parkinson disease: akinetic, rigidity, and tremor. So when I talk about this akinesis, right, we typically describe it as bradykinesia. Bradykinesia, slowness of movement, right? And there is rigidity of the muscles. Okay, and then there is tremor. Few points to remember. The tremor here is rest tremor, right? It is a rest tremor. Tremor is there at rest, and it typically affects upper limb more than lower limb, right? It typically affects distal parts of distal muscles more than proximal. So distal muscle matlab small muscles in your hands, proximal matlab around your shoulder, right? It typically affects here, not shoulder. These patients are not having murmur, the tremor of the shoulder, they're having the tremors of the hands, right? Small muscles. Upper limb more affected. Their legs are not having pill rolling tremors. Very late they will present, but hands, that's the starting point, right? That is a tremor. The rigidity in a Parkinson disease patient, right? Whenever you describe rigidity, you have to also describe whether the extra-axial muscles or the limb muscles are more affected or the axial muscles are affected. In case of Parkinson's, there is both axial involvement plus extra-axial. So the rigidity means increased tone, right? So the limb muscle tone is increased, and your axial muscle, in the sense the muscles of your front of the chest and abdomen and back of your spine, right? Those are all having increased rigidity or increased tone. And when you talk about extra-axial, you have to remember that anterior muscles, front ke side jo muscles hain, they have more tone than the posterior muscles. So the net result of it is the patients are now bending forward. That is why you get a stooped posture in patients with Parkinson's disease. Stooped posture, we call it as bent spine syndrome, because the anterior muscles, they are having an increased tone, so they are contracting more. Your abdominal muscles, chest muscles, they are contracting, so you are bending forward. Equal contraction is not happening from your posterior side muscles, so they are giving up, right? So you are bending forward. This bending forward is responsible for their gait, because when they bend forward, their center of gravity is shifted forward, so they tend to fall. To prevent falling, they walk faster, shorter steps. That is what you call as festinant gait. Okay. Now this bradykinesia means slowness of movements. Spontaneous movements as well as active movements are slowed. What are the spontaneous movements? Blinking of your eyes, hand movements during walking, they are also slowed down. So by the time you see a Parkinson's patient walking into your OPD only, you can identify, his movements are somewhat abnormal, his hand movement are not of full range, they're reduced, his eye blink is reduced. Okay. Apart from that, when you ask him to do an active task or get up and walk, you will notice that there is slowness of movements. Okay. When you tell something to them, right, a very sad news or a good news, by the time their brain processes and it gives out as an expression, your expectation of the expression and that moment is already gone, because their expressions are happening very slow. So there is an asynchrony between your expectation, observer's expectation, and patient's response in terms of expression. It is not that they do not express at all, but the expression is reduced and it is very slow. अभी मैंने joke सुनाया, but because of the slowness of the moment, जब मैं दूसरे joke पे चला जाता हूँ, some smile appears on their face, right? That is why we call it as hypomimia or mask-like feces. The hypomimia is because of bradykinesia. The movements on the face are appearing late, bradykinesia. Yeah, the median is 4 Hz. So the answer for this question is Parkinson's disease or Parkinsonism. Okay, cool. Let's move to the next question now. Earliest manifestation of progressive supranuclear palsy. It is related to one of the previous questions, right? We did discuss about what is called as Parkinson's disease, and I told that it comes under a broad heading called as akinetic rigid syndrome. Under this only, there is another example, which is progressive supranuclear palsy. This can be also called as atypical Parkinsonism. Under that heading, you can describe it, or you can also describe it as Parkinson plus syndrome. Progressive supranuclear palsy. 2-3 important image-based questions are possible from this. Okay, what is the earliest manifestation? So I told you progressive supranuclear palsy is also a akineto-rigid syndrome. Rigid syndrome. Okay, akineto-rigid syndrome. So these patients also have bradykinesia, reduced movement, and these people also have rigidity. But the rigidity here is different from the rigidity of Parkinson's disease. So when I spoke about the Parkinson's rigidity, I told axial and extraaxial are both affected. That is why you have that cogwheel rigidity of the limbs, and you also have that stooped posture because of increased axial anterior muscle tone. In case of the progressive supranuclear palsy, it is mainly axial. Extraaxial are not affected. It's mainly axial. The limbs are not affected much. Axial. And unfortunately, here it is the posterior group of muscles. Posterior group of muscles are more affected than anterior. So when posterior muscle tone is increased, right, your neck is getting extended up because it is all contracting. This is what we call as retrocollis, right? So this posterior group of muscles rigidity leads to retrocollis. When side tilted, torticollis, right? When extended, retrocollis. It leads to retrocollis. And then there is degeneration of the brainstem, and that is causing a gaze palsy, right? Mainly the downward gaze palsy. So these people, that's why I said we call it as Parkinson plus syndrome. So the conditions where we call it as Parkinson plus syndrome, Parkinson's ka basic thing, akinetic and rigidity, they are there, plus some other neurological manifestations are there. One of that is the vertical gaze palsy, which is predominantly affecting the downward gaze palsy, right? So these patients, in addition to that, have downward gaze palsy. So when you have downward gaze palsy, you have difficulty in looking down, right? So now combine these two things. They have retrocollis, their head is extended up, and then I cannot look down. So when I'm walking, right, I'm seeing actually the interface between the sky and the land far away. I cannot see whatever is that is there in front of me right now, because neither my eyes can go down to look because I have a downward gaze palsy, nor I can bend down because of this retrocollis. So net result is I am asman ko dekh raha hu. I am only looking at the sky. I cannot look at the ground. So what will happen? I will fall, right? So that is why the earliest manifestation of patients with progressive supranuclear palsy is a frequent fall. And if you have diagnosed someone as having Parkinson's disease and quite early in the course of the illness, they come with repeated falls, right? That's a flag sign, red flag sign. You should start thinking of, it may not be Parkinson's disease. Mera diagnosis galat ho sakta hai. It may be progressive supranuclear palsy. Okay. Now, before we move forward, I want you to see three images which can be image based question. Okay, this This is a case of progressive supranuclear palsy, and you can see that this patient has developed retrocolysis, right? Neck is extended. Okay, that image you should be aware about. And then in this progressive supranuclear palsy, you get a sign called as procerus sign. So you know there is two frontal ridges here. Okay, this presence is called as procerus sign. Procerus sign. Okay, this is also seen in patients with progressive supranuclear palsy. And the third image finding, all of you are very much familiar with it, right? Can anybody tell me what is this image finding? So in progressive supranuclear palsy, there is atrophy of the tegmentum and there is normal cerebellum. Okay, so this tegmental atrophy leads to this finding, which I'm just drawing it out for you. So what do you see here? What do you see here? What is this sign called? कुछ bird के जरा दिख रहा है ना? All of us are familiar what this sign is called. Mehul Bhajani, it may be of some help, but it is little at high level, so may not be like appropriate for you. So what is this sign called? Right, it is called as hummingbird sign, right? So they can ask you, where do you see hummingbird sign? Hummingbird sign is seen in progressive supranuclear palsy. Okay, good. It is because of the atrophy of the tegmentum. Tegmentum यहाँ से atrophied है, it's like compressed it, and the other structure, cerebellum, everything looks normal, so it looks like a hummingbird. Okay, cool. That's about this question. Earliest manifestation of PSP is frequent falls. Okay, now moving on. According to Berlin criteria, moderate ARDS is defined as PaO2 by FiO2 of how much? Okay, ARDS is a very important topic from critical care medicine, apart from sepsis and shock. Right, all of you are right. That is hummingbird sign, that what we saw. So for the diagnosis of ARDS, currently what we follow is Berlin criteria, right? Berlin definition or Berlin criteria is currently followed. This is the most latest thing for the diagnosis of ARDS. So there are 4 parameters that we need to meet in ARDS for the diagnosis. One is hypoxia or oxygenation defect, oxygenation issues. Second one is you need bilateral or imaging changes which are bilateral imaging, and the third one is rule out other causes for similar presentation. Okay, mainly you have to rule out the cardiovascular causes, because cardiovascular pulmonary edema also can look like ARDS only, right? So oxygenation wise, we are looking at PaO2 by FiO2 ratio. Okay, so in the Berlin definition, when the PaO2, see normal PaO2 by FiO2 ratio, I have to tell you, normal is usually more than 400. Okay, normal is usually more than 400. When it is between 300 to 200, it is called as mild. Okay, when it is between 100 to 200, you will call it as moderate, and when it is less than 100, you will call it as severe. Less than 100 is severe, 100 to 200 is moderate, 200 to 300 is mild. As long as it is 300 plus, it is acceptable. Most normal individuals, it will be 400 plus. Okay, previously whatever now we call as mild, 200 to 300, before this Berlin definition, this was called as acute lung injury, ALI, acute lung injury. We no longer follow that terminology, right? There is nothing called ALI. So whatever was ALI is mild ARDS. So if at all they ask you a question, whatever was called as ALI now fits into what category? According to Berlin definition, it fits into mild ARDS. Okay, 100 to 200 is moderate, and less than 100 it is severe. Okay, now coming to the other parameters. A patient who presented with respiratory distress, he has hypoxia meeting any of these criteria, mild or moderate or severe, depending on his PaO2 by FiO2 ratio. We need to prove that whatever is responsible for it is a bilateral condition. The chest imaging should show bilateral opacities, and there should be no alternative explanation. It shouldn't look like, okay, bilateral upper lower consolidation or lower lower consolidation or something like that. Okay? There should be no alternative explanation. Okay, should be bilateral opacities, and this edema can be because of either ARDS or cardiogenic. So to ruling out cardiogenic, previously we used to do what is called as pulmonary capillary wedge pressure. Okay, but the current Berlin definition does not recommend it, because pulmonary capillary wedge pressure is only possible if you do a right heart catheterization. So you need to take the patient to cath lab, put a right heart catheter, and then measure the pressure, or Swan-Ganz catheter. Not possible practically. So we were not doing it. So guidelines have also ditched it. So all it says is you should do some objective assessment of cardiac function, and the recommended mode is echocardiography. Kafi hai. Right now it's like enough. You have the right context, and echocardiography turns out to be normal. It is enough to call it as ARDS. Only when echocardiography is abnormal and you need to do further distinction, then maybe you can do right heart catheterization, not for all patients. So cardiac cause right now are ruled out not by right heart catheterization but by 2D echo. Okay. And then you also need a temporal correlation between some insult and the symptom onset, because ARDS is caused by like chest trauma, infections, or something like that, transfusions, TRALI. So that insult, transfusion, or chest trauma, or infection to the onset of the patient's ARDS symptoms should be less than 7 days. If it is more than 7 days, it could be something else. Okay, so this temporal correlation is also important. Within 1 week of the onset of insult, patient should develop symptoms. Okay, now going to the question, the answer is going to be very easy. Less than 100 will be severe, 100 to 200 moderate, right? And 200 to 300 is mild, which was previously called as ALI. This can be counted normal. Okay, so I hope you will be able to remember these Berlin definitions. Now we'll move on to the next question. Simple and easy question. A chronic liver disease patient presented with abdominal distension, jaundice, and pruritus. So expected, right? Chronic liver disease, he has abdominal distension pointing towards ascites. Jaundice, that means there is some amount of decompensation happening. Pruritus, expected. So he had ascites. We have done the fluid analysis and it shows a neutrophil count of more than 650 per cubic millimeter. What is the most likely diagnosis? Intestinal obstruction, malignant ascites, tubercular ascites, or spontaneous bacterial peritonitis? Yeah, which one is likely? What do you think? Is this patient suffering from spontaneous bacterial peritonitis, or you would think of some other causes, right? What is the minimum criteria required for diagnosis of spontaneous bacterial peritonitis in a patient of ascites? Right, good. All of you are right. So I think I don't need to discuss much. Yes, it is a case of spontaneous bacterial peritonitis. So any patient of ascites, right? Any patient of ascites plus ascitic fluid polymorphonuclear count, or the neutrophil count more than 250 per cubic millimeter is sufficient for the diagnosis of spontaneous bacterial peritonitis, right? It is sufficient for the diagnosis of spontaneous bacterial peritonitis. This patient has more than 650, so I would be calling it a spontaneous bacterial peritonitis. Okay, I hope you guys are very much familiar with what is called as SAG score for distinction between the causes for ascites. Because of the lack of time, I'm not getting into that details, but those who don't know, I would strongly recommend that please spend some time with the SAG score, because mostly MCQs are going to come from it. At least one MCQ we can expect on a SAG score. Okay. Now coming to the next question. JVP findings in a patient with irregular pulse of 120 per minute and a pulse deficit of 20 is what is that you are going to expect? JVP finding in a patient with irregular pulse, the rate is 120 per minute and a pulse deficit of 20. Okay, so first you have to understand what is the diagnosis of this description, then you will be able to tell what is the JVP finding. Yes, please spend some time on SAG. Right now I'm running out of time, so I will skip it, but it is a very, very important section. Okay. Irregular pulse of 120 and pulse deficit of more than 20. Okay, see, causes for irregular pulse. What are the causes you can think of for irregular pulse? Yes, first thing that should come to your mind is yes, atrial fibrillation. Okay, those patients who have frequent ventricular or atrial ectopics, can they have irregular pulse rate? Yes. Frequent ventricular premature contractions and atrial premature contractions, they can have. Okay, patients with multifocal atrial tachycardia, they can have irregular pulse. Okay, then patients with complete heart block, they can have irregular pulse. Among this, complete heart block will be a brady, right? It will have significantly low heart. It will be a bradyarrhythmia, not a tachyarrhythmia. So these three are tachyarrhythmias: atrial fibrillation, frequent VPCs and APCs, and MAT are tachyarrhythmias. Okay, so this patient has heart rate 120, so these three fit into it. Now, what is the role of pulse deficit? Pulse deficit, in the absence of ECG, earlier practice, it used to help us identify atrial fibrillation, right? In other conditions, the pulse deficit is going to be less than 10. Even in normal physiological state, pulse deficit is going to be less than 10. When it is more than 10, in an irregular pulse, it points towards atrial fibrillation, right? So please remember this one point. Irregular pulse plus pulse deficit of more than 10 suggests atrial fibrillation. Now, what do I mean by pulse deficit? Pulse deficit means the difference between the heart rate on auscultation and on palpation. So, simultaneously, if you auscultate, right, one person auscultates patient's heart rate, the other person is taking the pulse rate. The difference, that is pulse deficit, right? So, pulse deficit is nothing but heart rate minus pulse rate. So that simply means that some of the sounds that you heard are not transmitted in the form of pulse. That means the force of contraction was inefficient. That typically occurs in atrial fibrillation. Okay, so if you remember that much, it is enough. So in this case, pulse deficit is more than 20. So we are talking about atrial fibrillation. So on the JVP, what wave changes we will be seeing in atrial fibrillation? Well-known fact, right? What do we see on JVP in atrial fibrillation? We will see absent A waves on the JVP. Yeah, on the ECG, you will see absent P waves. Atria are not contracting. The JVP, the first A wave was because of the atrial contraction. The atria is not contracting. It is fibrillating, shaking, not contracting. So A waves you will not see. So you will be seeing absent A wave. That's very typical finding of atrial fibrillation, right? So instead of directly asking you what do you see in atrial fibrillation, they are given a story and then asked you what is the JVP finding. Okay, let me move to the next question now. An MRI scan of a pregnant female with complaints of galactorrhea revealed a large pituitary tumor who is not willing for surgery. Which of the following is the best treatment for this patient? Okay, this question is from one of the previous exams. I wouldn't really like to frame the question like this, right? Because whatever they're talking about, there is galactorrhea and there is a pituitary tumor. So what is the likely diagnosis? You will be thinking of prolactinoma, right? What is the treatment of choice for prolactinoma? Treatment of choice for prolactinoma. Prolactinoma we classify as micro and macro and giant prolactinoma, right? Prolactinoma is called as microprolactinoma, macroprolactinoma and giant prolactinoma, right? Micro means it is less than 1 centimeter or 10 millimeter, right? When it is called as macro is when it is more than 1 centimeter and less than 4 centimeter. And when it is more than 4 centimeter, we will call it as giant. Okay, you have to remember that prolactinoma, regardless of the size, here they have mentioned that there was a large pituitary tumor. Large, here they have added the word. But in a case of prolactinoma, regardless of the size, regardless of the symptoms, the drug of choice or treatment is always, first choice is pharmacotherapy, because most of these prolactinomas shrink in size. Okay, why they shrink in size once you start the pharmacotherapy? Because when we were discussing the hyperprolactinemia, I told you that the prolactin is under the inhibitory control of hypothalamus in the form of dopamine. So dopamine comes and inhibits. It inhibits not only prolactin release but also replication of prolactin producing cells. Okay, when you cut this inhibition, then the cells are replicating, they are making a tumor and they are secreting more prolactin. If you give dopamine agonist, right, they will suppress cell division as well as prolactin production. So because they're suppressing cell division, the tumor will shrink. So regardless of the size, always treatment of choice is pharmacotherapy, right? And the drug of choice are obviously dopamine agonists are the drug of choice. Two commonly used drugs are cabergoline and bromocriptine, right? And you have to remember that cabergoline is preferred over bromocriptine. Why we prefer cabergoline over bromocriptine? The reason for that is cabergoline is long acting. It is long acting, right? Once or twice a week dosing is enough. Because it is long acting, ना हफ्ते में एक बार या 2 बार काफ़ी है. Bromocriptine needs to be taken multiple times a day, not even like OD. You need to give it TID or QID multiple times a day to achieve the result. So that is why it has fallen off preference. The preferred agent right now is cabergoline. Okay, only in pregnancy, if you need to continue dopamine agonist, we give bromocriptine, right? It is preferred in pregnancy. If you need to give, preferred in pregnancy, especially first trimester, because we don't know much about the safety of cabergoline, but we know about the safety of bromocriptine. So in pregnancy, it is preferred. So here, because they have not mentioned cabergoline, my right choice would be bromocriptine. Okay, cool. Let's move to the next question now. A patient who ingested 10 tablets of paracetamol was brought to emergency room. He has developed oliguria and liver function test showed deranged values. Which of the following can be used in the management of this condition? Which of the following can be used in the management of this condition? So you are all familiar with the antidote, right? The antidote is N-acetylcysteine. Antidote for paracetamol toxicity is N-acetylcysteine. So this is familiar. I'm not going to get into the more discussion of it, but I will ask you one question. Do we give N-acetylcysteine to all patients who have come with paracetamol consumption? Do we give it to all patients who have come with paracetamol consumption? The answer is no, right? We don't give it to all patients. Then what is the deciding factor, right? What helps us to make a decision about whether you want to give paracetamol or not? Not paracetamol, the N-acetylcysteine. Decision to treat with N-acetylcysteine is based on you have to take up serum paracetamol levels 4 hours after the consumption of paracetamol or anytime after that, not before that. And then you will plot it on a nomogram, right? So they can ask you the name of that nomogram, name of the nomogram. And on the nomogram, if it falls above the treatment line, the levels fall above the treatment line, you will give N-acetylcysteine. If levels are below the treatment line, then the patient is not at risk of developing liver injury. We don't need to give N-acetylcysteine. So you have to remember the name of that nomogram. Rumac-Matthew nomogram. It's called Rumac-Matthew nomogram, right? If you remember name, it's kind of enough. Rumac-Matthew nomogram. This is a nomogram. Okay, when you look at the nomogram, like hours after the consumption, like how many hours after the consumption of paracetamol you have taken the serum levels and what is the paracetamol level on this axis. So we will meet at one point. Let me say that this particular patient's paracetamol level is taken 16 hours after the consumption and it falls here. Okay, you can see 2 lines here. One line is called as treatment line. The other line is called as Rumac-Matthew line. Anything which falls above the Rumac-Matthew line is associated with liver toxicity. But for patient safety, we want to treat much lower. It is like 25% lower. So anything that is above the treatment line, we should treat. Okay, and the line begins at 4 hours, not before that. Because when you take paracetamol, its peak levels are reached after 4 hours, not before that. So if you draw before that, patient's peak levels would not have reached. So you will decide like, okay, it is falling below the treatment line. Let us not give N-acetylcysteine. But 1 or 2 hours later, his levels will fall here. So that is why after 4 hours only we can do it. Okay, not before that. Okay, cool. So this patient, the drug of choice would be N-acetylcysteine. Our decision will be based on Rumac-Matthew nomogram, looking at the paracetamol levels. Yes, another important point. There are some exceptions to use of this Rumac-Matthew nomogram. If patient is already having liver dysfunction, then don't waste your time in drawing the serum paracetamol level and plotting it on the Rumac-Matthew nomogram. Directly give N-acetylcysteine. So in this case, he has organ injury. Oliguria and liver function tests are already abnormal. So without plotting on the Rumac-Matthew nomogram, this patient requires N-acetylcysteine. Okay. Second exception is when patient has taken lethal doses. 10 gram single consumption is considered as lethal. 4 grams is toxic, 10 gram is lethal. So if it's taken lethal dose, don't waste your time in waiting for the paracetamol levels. Give it out. That is second exception. The third exception is all this nomogram is based on a single point consumption. Is taken now, 4 hours later his paracetamol levels peak and after that it starts coming down. Based on that assumption is nomogram is designed. But if I take at intervals, like I take 5 tablets abhi, आधा घंटे के बाद another 5 tablets, 2 hours later another 5 tablets. So if there is spaced consumption, then this nomogram ka like chitde ud jate hain. It is not reliable or not acceptable to plot it on the nomogram. Better give N-acetylcysteine, right? So remember 3 exceptions for use of nomogram. Okay, good. Now let me move to the next question. A patient presents with seizure. On evaluation, his urine osmolality is 100 milliosmoles per kg and serum osmolality is 270 milliosmoles per kg. What is the expected electrolyte abnormality in this patient? Madhavan Kuti, yes. Glutathione is involved in the metabolism of paracetamol into non-toxic substances, so you need to replace that. That's why we use N-acetylcysteine. Nowadays, glutathione infusions are also coming into the market, so some of us have started using that also as an alternative to N-acetylcysteine. We can also use S-adenosylmethionine, SAM, also as an alternative to N-acetylcysteine if it is not available. N-acetylcysteine is readily available, so we go ahead with it. Okay, good. So yes, all of you, I think you are getting the right answer. It's very straightforward, right? Okay, now what are the components or contributors to serum osmolality? What are the osmotically active substances in the plasma? Osmotically active substances in the blood which are contributing to the serum osmolality. Most important ones, or let me rather call, like, there are so many micromolecules, the major osmotically active substances in plasma or blood. The major contributor is always sodium, right? Sodium, glucose and urea. Sodium, glucose and urea, these are the three major contributors to the serum osmolality, because they are osmotically active. Depending on their levels, you have a serum osmolality. And in fact, you should remember this formula. Serum osmolality is 2 into sodium plus blood urea nitrogen divided by 2.8 and glucose divided by 18. Now from the equation, tell me what is the major contributor to the serum osmolality? Which one is the most important contributor? ठीक, like normal blood glucose कितना होगा? Let me say 120 divided by 18. So इसका contribution कितना हुआ glucose का? 120 divided by 18 is almost like, let me say 120 divided by 20 कितना होगा? 6, right? Very minimal contribution. What is the normal blood urea nitrogen? Around 40 divided by 2.8. What is its contribution? Very minimal, right? What is the serum normal sodium level? Minimum is 125. Multiplied by 2, कितना हो गया? 270. So what is the normal serum osmolality? Normal serum osmolality is in the range of 285 to 290 milliosmoles per kg or per liter, right? That's the normal serum osmolality. So in this normal serum osmolality, 270 is coming from sodium only. So the major determinant of your serum osmolality is sodium. If sodium goes low, serum osmolality goes low, right? If glucose goes low, say, let me say from 120 it has become to 70, right? So when it was 120, it was adding 6 milliosmoles to the osmolality, roughly. Okay, when it becomes 70, how much osmolality decrease is going to happen? 70 by 18 कितना हुआ? 3.5 or something. So the osmolality is decreasing by 3.5. But imagine the sodium 135 to 110, right? So 110 into 2 is 220. So what is the contribution? कितना decrease हुआ? 270 से सीधा 220 आ गया. 50 milliosmoles decrease in the serum osmolality. So the major determinant of serum osmolality is sodium. So in this case, forget about what is happening with urine osmolality. Depending on the cause for hyponatremia, it will be different. But the moment I see that serum osmolality is less than normal, normal is 285 plus, I know it is hyponatremia related, right? Can we have a condition where there is hyponatremia but serum osmolality is normal or increased? Hyponatremia with serum osmolality normal or increased? Hyponatremia means your serum sodium is less than 135, okay, and your serum osmolality is more than 280. Can we see such a picture? Yes. What we call this as? We call it as pseudo hyponatremia. Why we are calling it a pseudo hyponatremia? If there is true hyponatremia, sodium has gone down, osmolality should be low, right? If sodium has gone down genuinely, osmolality should be low, because that is the main contributor to our osmolality. But there can be a condition where glucose has gone very high, staggeringly high, like you see in some diabetes patients with 400, 500 sugars, right? To maintain the serum osmolality, what happens is the sodium gets shifted into the intracellular compartment. Whatever sodium was there, because osmolality, body will still try to maintain it. So glucose is adding too much of osmolar components. So sodium will go into intracellular component and the plasma sodium will come down. But is it true hyponatremia? No, body sodium is still preserved. You reduce the glucose, the sodium that had gone out to the intracellular compartment will come back to the plasma, right? So that is called as pseudo hyponatremia. A classical example for that is your hyperglycemia. Okay, sometimes it can be a false lab estimation which can happen with hyperlipidemia and in patients with multiple myeloma. I'm not getting into the details why the lab is wrongly estimating it, right? It is just remember that it is a laboratory error. There actually the serum sodium will be normal. It has not even gone to the intracellular component, but presence of these other substances like the M protein in patients with multiple myeloma or too much of triglycerides in hyperlipidemia, that can interfere with the lab test and give rise to a pseudohyponatremia, right? Anytime you diagnose hyponatremia, first thing is to check the serum osmolality. If it is decreased, then only it is true hyponatremia. If it is not decreased, it is pseudohyponatremia, and according to that you can investigate further. Okay, so that question is done. We'll move to the 18th question now. A patient presenting with mid-diastolic murmur and JVP showing prominent A waves. What is the most likely diagnosis? Patient presented with a mid-diastolic murmur, JVP showed prominent A wave. So what we understand so far is A wave is because of what? A wave is because of atrial contraction. Atrial contraction. So when this is happening? This is happening during atrial systole ka last phase. Okay, parallelly the ventricular diastole is happening, right? Okay, so Naveen says mitral regurgitation, and Sanjit Mayangbam says it is tricuspid stenosis. Okay, let us see what happens. Okay, so when you talk about the heart, right, this is your left side of the heart, this is your right side of the heart. So from here you have tricuspid valve, here your mitral valve. Okay, so when atria is contracting to empty its last phase of systole, the left ventricle is receiving the blood. Pulmonary vein valve will be closed, PV will be closed, the tricuspid valve is open, the blood is moving from the right atrium to the right ventricle, and it is like giving the last push, that is giving rise to our A wave. Okay, now if it encounters a resistance because the valve is tight, if it encounters a resistance because the valve is tight, right, what is that? Tricuspid stenosis. What will happen to the pressures in the right atrium? It will further go up, right? It will become, the A wave will become much more prominent. Because the valve is tight, it is squeezing against the tight valve. So pressure inside the right atrium is going up. So the A wave is becoming much more prominent. So that is very typical of the tricuspid stenosis. Can mitral stenosis cause that? Can mitral stenosis cause that? Mitral stenosis, mitral regurgitation, they can cause a prominent A wave, but that is only possible when the mitral stenosis or mitral regurgitation has led to left atrial enlargement. This left atrial enlargement has caused pulmonary venous congestion at the level of lungs. So because of that, pulmonary artery pressure is gone up. Because of the pulmonary artery increase in the pulmonary artery pressure, you have developed the right ventricular hypertrophy. Now the right ventricle is not relaxing well. So because of that, right atrium is doing overwork. That can lead to prominent A wave. So MS and MR, right, or any of the left heart pathology can cause a prominent A wave only if it has led to development of pulmonary hypertension and right ventricular hypertrophy. So in this scenario, that is not happening. They have not mentioned anything suggestive of that. So I would not consider any other option but straight out tricuspid stenosis. Tricuspid stenosis is the explanation. Now, do we agree with the diastolic murmur here? Tricuspid stenosis, we get a diastolic murmur or a systolic murmur. When is this movement happening? The blood movement from the right atrium to the right ventricle. The right ventricle is in the diastole, right? It is in the relaxed phase. That is where the blood is moving. So this abnormal movement or the turbulence created by this narrow valve is giving rise to the sound. So this movement is happening during the right ventricular diastole. So it will give rise to a diastolic murmur. So everything fits into the picture. So it is a case of tricuspid stenosis. Okay. I have two more questions. We will solve that and wind up for the day. Which of the following defines sepsis according to sepsis 3 criteria? Sepsis according to sepsis 3 criteria. Suspected or documented infection and any two of the SOPA points. Suspected or documented infection plus vasopressor therapy to maintain mean arterial pressure of more than 65 millimeters of mercury, or serum lactate more than 2 millimoles per liter despite adequate fluid resuscitation, or suspected or documented infection plus 2 SIRS criteria, or all of the above. Yes, TS, MS diastolic murmur, MRTR systolic murmur, right? ASPS systolic murmur, ARPR diastolic murmur. You can just conceptually think when is the abnormal movement of blood is happening, whether it is happening during systole or diastole, and you have the answer. Okay, so please remember, we are no longer, right, in medicine we no longer follow SIRS criteria for anything, right? Surgeons may be still using it for some of their utilities. For medicine, SIRS criteria is out of the window, right? For sepsis, we follow this sepsis 3 criteria, and according to sepsis 3 criteria, sepsis is defined as, it is defined as suspected or documented, like culture positive or evidence of infection in the imaging X-ray or something, or clinically or suspected or documented infection plus more than or equal to 2 SOFA points. SOFA stands for sequential organ failure assessment. Sequential organ failure assessment, more than or equal to 2 SOFA points. Okay, or a rise in SOFA points by more than or equal to 2. By more than or equal to 2. Like, my definition is very, very important here. SOFA is sequential organ failure assessment. You are assessing multiple organs for their failure parameters. Like, you are looking at platelet count, you are looking at liver function, you are looking at kidney function, you are looking at GCS. Okay. Now, some of the patients might be having a pre-existing disease of that organ. Like, if I have, for a normal individual, the normal SOPA score is 0, because you have no organ which is dysfunctional. So for a normal individual, it is 0. Okay, but you may be having an existing comorbidity. I may be having CKD, so in that case my creatinine and urine output may be altered, and it might give me some SOPA points, right? Or I may be having a liver disease, so it might give me some SOPA points. In that case, in such a patient, sepsis can occur in CKD, CLD, all those patients. In fact, they are at more risk than a normal individual. So in them, whatever is their baseline SOPA point, uske upar during a period of infection, if it goes by 2, like let me say the baseline of this patient, I am suspecting that he has an infection, okay, and his baseline SOFA is, let me say, 4. Now from 4th it has become 7, it is increased by more than 2, then also I can call it a sepsis. Okay, a normal individual, his baseline will be 0, 0 se 2 ban gaya, I will call it as sepsis. We no longer follow SIRS criteria. Okay, so what option makes sense here? Suspected or documented infection and any 2 of the SOPA points, it becomes the definition of sepsis. Okay, the second thing we are seeing here, no, suspected or documented infection plus vasopressor therapy needed to maintain a mean arterial pressure of more than or equal to 65 millimeters of mercury, or the serum lactate more than 2 millimoles per liter despite adequate fluid restriction. What does it indicate? Okay, this is a definition that we follow for septic shock. According to the sepsis 3, this is how we define septic shock. In any patient where you are suspecting that he has an infection or there is a proven infection, if such patient is like sepsis, they come to hospital, their BP may be low at presentation, you will not just call it a septic shock, you will give fluids. After that BP normalizes, it is still sepsis. But BP does not normalize even after fluid resuscitation, and you need to give vasopressors so that his mean arterial pressure is maintained above 65. You need to give noradrenaline or any other vasopressors. That defines septic shock. Or BP is fairly maintained, but his serum lactate is more than 2 millimoles per liter. Serum lactate is an indicator of tissue hypoperfusion. High lactate, that means tissues are not getting adequate blood supply, all your muscles and peripheral tissues, so they are going into anaerobic metabolism. That is why your lactate is going up. So if the lactate is high, that means your tissues are pushed to anaerobic metabolism. Somehow your BP is maintained, but your tissues are anyway not getting well perfused. So it is also a marker that you are in shock. So if you are requiring inotropes to maintain BP, or if you are requiring inotropic support so that serum lactate is kept below 2, or despite giving the fluids the lactate remains more than 2, all that will go into call the patient as having septic shock. Okay, clear? They can ask you one more MCQ. What is the inotrope of choice for septic shock patients? For septic shock, this is a repeatedly asked MCQ. So please remember, it is noradrenaline. Noradrenaline. Okay. Like if noradrenaline adequate is not helping, right, then as add-ons, you can consider vasopressin and adrenaline. Vasopressin and adrenaline. And please remember, dopamine is to be avoided. There are only selected indications for use of dopamine, and dobutamine has no role in management of the septic shock. Dobutamine is for the cardiogenic shock. It is for cardiogenic shock. It has no role in septic shock. Why are we avoiding dopamine and why noradrenaline is preferred? See, septic shock is a high cardiac output state shock, or it is a distributive shock where heart is doing overworked. Peripheral tissues are not getting blood anyway, but heart is still doing overwork. Now, heart rate will be very high in patients with septic shock. Like you have already heard about Sear's criteria, right? So there sometimes you used to talk about the rate, heart rate. Septic shock, heart rate will be very high. Now, if you give a inotropic agent, which is a potent chronotrope, inotrope means it will increase the BP, chronotrope means it will increase the heart rate. Dopamine is a very potent chronotrope. So if you increase the heart rate, myocardial oxygen demand will increase. Already it is contracting vigorously. Now increase the rate more, its need for oxygen supply will increase. If the BP doesn't improve, its perfusion also will not improve. It will fail further, right? It will worsen the situation. So dopamine should not be given because it is a more potent chronotrope. Noradrenaline has a sweet balance between inotropic and chronotropic activity. Okay, then adrenaline also. Vasopressin is a non-catecholaminergic inotrope of choice. So there was a PGI question asking you which of the following is a non-catecholaminergic inotrope of choice for management of sepsis. So they had mentioned all the same options: noradrenaline, vasopressin, adrenaline, and dopamine. Obviously, the word non-catecholaminergic is something that we need to keep in mind. Noradrenaline, adrenaline, dopamine, these are all catecholaminergic. So vasopressin being a pituitary hormone, it's non-catecholaminergic, so that becomes the choice if they mention the word non-catecholaminergic. Otherwise, preferred choice is noradrenaline. Okay, good. Now the last question for the day. Okay, all of the following are correct regarding diabetes insipidus. Okay, which of the following are correct regarding diabetes insipidus? Polyuria and polydipsia are common symptoms. Urine is of low osmolality and specific gravity. Lithium is used in the treatment. It is potentially lethal if hypothalamic thrust center is damaged. Okay, now tell me what are the correct statements. First point we need to know is diabetes insipidus. Is it a condition due to vasopressin or ADH excess or deficiency? ADH excess leads to SIADH and hyponatremia. Diabetes insipidus is due to ADH deficiency, right? Diabetes insipidus is due to ADH deficiency. So when there is ADH deficiency, ADH is concerned with plain water absorption, right? It is concerned with plain water absorption. So if ADH deficiency is there, there is excessive plain water loss in the urine, right? So when you're not losing sodium, you're not losing potassium, you're not losing other electrolytes, you're only losing plain water. ADH is only to do with plain water absorption or release, right? So if plain water excretion increases, urine will become concentrated or dilute. ADH is sufficiently not there, so plain water absorption is affected. You're losing a lot of plain water in urine, so your urine becomes dilute. So when it is diluted, what happens to osmolality and specific gravity? It will be low, right? Solutes are very less, too much of water is there, so your urine osmolality and specific gravity will be low or decrease. So it's a true statement. It's a true statement, right? Okay, when you start losing lot of water, what do we call it as? Polyuria, right? We will call it as polyuria. Now when you are adding too much of water in the urine, urine will become diluted, right? It will not get concentrated. The plasma gets concentrated. Plasma osmolality in diabetes insipidus might go high if there is a hypothalamic disease. I'll tell you that point in a bit. But in a diabetes insipidus patient, the urine osmolality and the specific gravity will be decreased. They are passing dilute urine. In fact, if you go back to the history, our ancestors, like some old time scientists or doctors, diagnosed two important causes for polyuria, and they named them as diabetes mellitus and diabetes insipidus. So they called this as insipidus because insipid means tasteless. So whoever was the great doctor, he tasted the patients of polyuria, their urine. The one set of patients whose urine tasted sweet, he called them as diabetes mellitus. And those patients whose urine was absolutely tasteless because it was very dilute, not even like normal urine, he called it the diabetes insipidus. So with this you can remember that you will be expecting a dilute urine, so osmolality and specific gravity will be low. So that's first true statement. Okay, when you are losing too much of water, is there any defense that body can pose for it? Is there any defense that body can pose for it? See, diabetes insipidus has led to polyuria. Okay, so when you lose too much of water, right, the impact of this on the serum osmolality is increasing, because Urine is becoming dilute, but the plasma is now becoming concentrated. Serum osmolality is increasing. It is going more than 290 that we took as a normal range earlier. So when serum osmolality increases, there is a osmoreceptor center. Osmoreceptors are present in the hypothalamus. They can ask you more precisely where they are present. So there is organum vasculosum of lamina terminalis, which is a circumventricular organ where there is no blood-brain barrier. So because there is no blood-brain barrier, quickly this area gets to know that there is osmotic change happening. Okay, so in response to this, it can stimulate the pituitary to increase the ADH production. If there is a problem, it will not be able to do. So it will stimulate the pituitary to produce ADH. If there is no issue with the pituitary, the ADH will come and it will try to solve this polyuria problem, increase the water absorption. The second thing it can also do is, it can also stimulate the thirst center. And this thirst center will make sure that you have polyuria, you are losing a lot of urine, lot of water, you feel thirsty, you drink a lot of water, right? So the thirst center gets stimulated and this will lead to polydipsia. So can diabetes insipidus be associated with polyuria and polydipsia? Answer is yes. As long as polydipsia is there, right? This polydipsia, because you start drinking more, it will normalize serum osmolality. So in a diabetes insipidus patient, pathophysiologically serum osmolality should be going high, but it gets corrected by polydipsia. So that is why these patients do not have the osmotic symptoms. Their own problem is that I'm peeing a lot of, like I'm spending half of my day in the bathroom. That is their complaint that they come to you. They don't come to you because of the symptoms suggestive of raised osmolality, because this polydipsia is correcting for it. It is pitching for it. Okay, but if you have a hypothalamic disease and the thirst center doesn't get activated, then you are not drinking more. You are not even aware that your plasma is getting concentrated. Increased serum osmolality is not even perceived if there is a hypothalamic disease. Then what will happen? You will not compensate. The osmolality keeps going up. You get dehydrated. Your BP drops and you die. Right? So if there is diabetes insipidus accompanied by hypothalamic disease, it is associated with very high mortality because you will not have this polydipsia as defense. Okay. So this statement makes sense. If it is potentially lethal if hypothalamic thirst center is damaged. It makes sense, right? It's a true statement. Okay. First one is polyuria, polydipsia are common symptom. That's also true statement. Okay. Now when you look at the options, you don't have anything which mentions lithium, and you have to remember that when you talk about diabetes insipidus, we classify diabetes insipidus as central and peripheral, right? Diabetes insipidus is classified into three categories. One is central diabetes insipidus, then peripheral can also be called as nephrogenic diabetes insipidus, and then you have gestational diabetes insipidus. Okay, in central diabetes insipidus there is either problem with the hypothalamus or the pituitary, right? There is a pituitary tumor or a pituitary mass or pituitary injury or a hypothalamic causes are there. In nephrogenic diabetes insipidus, the ADH receptor defect can be there. ADH receptor defect can be there. So pituitary is producing sufficient quantity of ADH, but this ADH is coming to act on the kidneys to increase the water absorption, but unfortunately the receptors have problem. So even if the ADH is very high, the receptors will not be able to carry out the action. So you still have polyuria, you will keep losing water. Okay, that is one problem. Second, even if the receptor is fine, there is something called as aquaporin channels which are concerned with water absorption. Once the receptor is stimulated, aquaporins are the ones which are causing the water absorption. If they have a problem at the level of kidney, again it can be associated with nephrogenic diabetes insipidus. Aquaporin 2 defect. Okay. Then third, drugs can interfere with ADH action at the level of the kidney, and they can cause diabetes insipidus. Okay. And the most common drug responsible for, or most common cause for drug-induced NDI is lithium. Drug-induced nephrogenic diabetes insipidus is lithium. Lithium is the most common cause. So we know that lithium can indeed cause diabetes insipidus. It is not used for treatment. Right? We use lithium for treatment of mania and major depressive psychosis or bipolar disorders, bipolar and mania, rather than for the nephrogenic diabetes insipidus. It can cause NDI, not used for treatment. So 1, 2 and 4 are true statements, right? So how many of you gave the right answer? Correct answer here is 1, 2 and 4. Okay, cool. So with this, we are signing off for today, guys. In another half an hour or 45 minutes, you can expect the annotated PDF. And if you have any doubts, and like previously, whatever questions we had shared on the PDF, I will be posting the answers and solutions for that on the Facebook group. The Facebook group is called as PW Meded. So please join the Facebook group and post your questions or queries, and whenever time we will connect and discuss. And if other than that, if you have any other requirements or request before this exam, you can post it there. And if I find time, 10-15 minutes, like if you want something to be done on ABG or ECG, anything that is bothering you, which is important for you, you can come out and tell me on the Facebook. Okay. See you guys. Have a good